Society. I extend a warm welcome to all the faculty and delegates who are stalwarts in their respective fields to enlighten us on topics of immense practical importance. Now, without further ado, let's move on to the program inauguration. Let's invoke the blessings of the Almighty with a prayer by Dr. Maji and lighting of the lamp.
Thank you.
I now invite President of Calicut ONG Society, Dr. Jyoti Ramesh Chandran, to deliver the welcome address.
Thank you, Dr. Smita. Obstetric management has undergone great revolution over the years with the development of technology and expertise, and definitely the human brain. Today's webinar is one such, showcasing the development in high-risk pregnancy management and labor by our eminent international faculty of repute who have contributed personally to exploring various aspects which they would be telling us today. It's a proud privilege for me to give a warm welcome as President of Calicut ONG Society. At the onset, I would like to welcome our mother society members of Kerala Federation of ONG, and the society has endorsed our conference. I extend my warm welcome to our President of KFOG, Professor K. Ambujam, and our vibrant Secretary of KFOG, Dr. K. Venugopal. I welcome our guest of honor, Dr. Alpesh Gandhi, the President of FOXI, Professor V.R.S. Rajshekharan Nair, who was our founder member and for a long time with us before he left to Trivandrum. Professor Gopinatham, who was the past president of KFOG, Professor Bhadran, who is our patron. I welcome our mentor and chairman of this webinar, Professor P.K. Shekharan, who has been working since so many months to make this day what it is today. And I welcome our secretary, Dr. Subhash. I'm most excited to welcome our distinguished international faculty, Professor Arulkumaran, Professor Emeritus, St. George's University of London, past President FICOG, RCOG, BMA. Sir has been ever obliging to share his experiences with Indians, and we are so happy to have him with us. Welcome, sir. Our next international faculty to welcome is Professor Gordon G. Smith, University of Cambridge, who is going to deliberate on FGR. Welcome, sir. Professor James Walker from St. James Hospital, University of Leeds, UK, who is going to talk on management of preeclampsia. Welcome, sir. Professor Eyal Sheena, University of Negev, Israel, who is going to talk on preeclampsia long-term complication. I remember his presence with us in Calicut a few years back. Welcome you, sir. Professor Alexander Haezel from University of Manchester, who is going to talk on preventing stillbirth. Welcome, sir. Patrick Obrien, University of London, Vice President RCOG, on topic of COVID-19 maternal and perinatal health. Welcome, sir. I welcome the chairpersons of various sessions for their presence at this webinar to share their experiences with the international faculty. I welcome each and every chairperson. I welcome all the office bearers of Cogs who have been working hard to make this a success. I welcome our Mr. Samarth and Eugenics for providing us the platform and support. Last but not the least, I welcome the delegates who have logged in. Thank you. And I request the chairman of the conference, Professor Sherien, for his address.
Respected colleagues and friends, a very happy new year to all of you. We are all happy to have the renowned international faculty deliberating on various topics of importance to us today, and we are eagerly awaiting their presentation. This webinar or the virtual conference of high-risk pregnancy and labor is endorsed by the Federation of Obstetrics and Gynecological Society of Kerala, and we acknowledge the presence of Dr. Ambujam, the President, and also Dr. Venugopal, the Secretary General. Many of our past presidents of the Kerala Federation, Dr. V. Rajshekharan Nair, Dr. Gopinath, Dr. V.P. Paili, Dr. Prasanna Kumari, Dr. Vinay Chandran, Dr. V.K. Chellamma, and Dr. Lididambiga, and the President-elect of the Kerala Federation, Dr. Ajit, and the Secretary General of the FOXI, Dr. Jaydeep Tang, are also, along with many senior professors, are also participating in this webinar. We are also always guided by our patron, Dr. S. Badran, and thank you, sir, for continued guidance for carrying out our activities. We are extremely happy to have Dr. Alpesh Gandhi, the President of the Federation of Obstetric and Gynecological Societies of India, the largest professional organization with more than 37,000 obstetrician gynecologists as its members, to inaugurate this conference. I take it as my privilege and to invite Dr. Alpesh Gandhi, President of the Federation of Obstetric and Gynecological Societies of India, to inaugurate this international conference of the high-risk pregnancy and labor organized by the Obstetric and Gynecological Societies of India. Sir, Dr. Alpesh.
Thank you, Dr. P.K. Sekharan, sir. Very good afternoon to all of you. Today's guest of honor, Dr. V. Rajshekharan Nair, Dr. P. Gopinathan, and Dr. K. Ambujam Madam, Patron Professor S. Badran, President KFOG, Dr. Ambujam Madam, and Secretary General, Kerala Federation, Dr. Venugopal, President COGS, Dr. Jyoti Ramesh Chandran, Organizing Chairperson, Dr. P.K. Sekharan, Honorary Secretary COGS, Dr. Subhas Malia, Incoming President, Dr. S. Ajit, esteemed faculties, international faculties, dear friends, a very good afternoon to all of you. At the beginning, I would like to congratulate Calicut Society and organizers, Organizing Chairperson Dr. P.K. Sekharan, and all the team members for this very, very interesting and very important webinar. I would like to congratulate all of you for continuing good academic in this difficult time of COVID-19 and for selecting a very useful topic, high-risk pregnancy and labor. Since last 2 decades, there is a lot of improvement because of the safety measures, quality care, use of technology, and latest development in the field of obstetrics. But even though we need to do a lot to reach the desirable level, I would like to congratulate members of KFOG, Kerala Society. You have already achieved the SDG goal, but across India, there are so many states where we have to achieve those desirable levels. And for all of us, these topics are very, very important. You have chosen, today you have chosen very interesting topics: pre-eclampsia, FGR, stillbirth, and Ctg monitoring, and at the end, a panel discussion on COVID-19, its impact on maternal and perinatal health. Hypoxia is one of the organizations in South Asian countries to come out with first GCPR on pregnancy with COVID-19. We also came out with our second GCPR, and we also came out with our registry of COVID-19 mothers. And in this registry, we have just few days back, number of cases reported were 2,700. So we have, and probably by this time we must have reached to 3,000 cases. So Hypoxia is very proactively and working on this, all the aspects of COVID-19 and pregnancy. So I'm happy to see that today we are also having this panel, and we are going to discuss all these important topics. And particularly you have invited a great eminent international faculties who are the experts of the field. I'm sure our delegates are going to be benefited a lot. I wish grand success to this webinar. I wish happy learning to all the delegates. On behalf of KFOG, I also would like to thank all the international faculties. Stay healthy, stay safe. Happy New Year to all of you. And thank you very much for giving me this opportunity, for this invitation, and for this honor. Thank you.
Thank you very much, sir. I now request our guest of honor, Professor V. Rajshekharan Nair, past President KFOG, Senior Consultant at SUT Hospital Trivandrum, and former Professor at Government Medical College Trivandrum, kindly say a few words.
Respected Chairman of the Organizing Committee, Dr. P.K. Shekharan, Patron Professor S. Badran, President of Calicut ONG Society, Jyoti Ramesh Chandran, Secretary Subhash Mallia, President Hypoxia, Dr. Alpesh Gandhi, President and Secretary of KFOG, Dr. Ambujaman Venugopal, and distinguished faculty members from different countries, and all my friends at Calicut and elsewhere. I am really immensely honored by this invitation to be part of this webinar on high-risk pregnancy and labor, and congratulate each one of you for organizing such a grand virtual conference with renowned international faculty. Ever since I joined Calicut in 1993, I was a member of Cogs and had the good fortune to be the president of Cogs for 2 consecutive years before I became the president of KFOG. Those days, the monthly meetings were real academic feast. I still vividly recollect the days, that is the early 90s, when we did not have LCD projection facility in Kerala. Dr. Shekharan used to bring LCD projectors from Bangalore for our monthly meetings. Even now, I preserve those slides prepared at that time as a memoir. The 10 years of my life spent at Calicut, that is from 1993, were virtually the prime time of my professional career. And at that time, I matured into an obstetrician with the support of my senior colleagues like Dr. Badran, Dr. Shekharan, and legends like late Dr. Maladi, Dr. E.K. Varghese, and Dr. Mukherjee. In fact, those 10 years were also the most hectic period of my life. In fact, the daily deliveries at IMCH during those days were 80 to 100, and you can see all sorts of obstetric complications described in textbooks in a day or two. And we have lost our great teachers like Dr. Tangam, Dr. Maladi, Dr. Mukherjee, etc. But I am happy that the young torchbearers of IMCH like Dr. Jyoti are continuing with the legacy, of course, still guided by eminent personalities like Dr. Badran and Dr. Shekharan. Once again, I wish to express my gratitude and affection to all of you and take this opportunity to congratulate the Calicut ONG Society for organizing such a wonderful conference and wish all success for the program. Thank you very much.
Thank you very much, sir. Next, I request Dr. P. Gopinathan, immediate past president of KFOG, retired deputy DHS, and consultant at Kannur Medical College, Anjarakandi, to say a few words.
Good evening to all of you. Respected Organizing Committee Chairman, Professor Shekharan sir, Badran sir, Sherien sir, the President of KFOG, Ambuja Madam, Secretary General, Dr. Venugopal, President of the Calicut ONG Society, Jyoti Ramesh Chandran Madam, Secretary Subhash Malya, all the senior professors, and all the delegates. I'm very happy to be here sharing this platform with you. And I congratulate the ONG Society of Calicut to organize such an international conference for the on topics of very importance that everyday practice. It is very important to have the knowledge of all these topics which we are going to discuss here. I don't want to speak much because all of them are waiting for the international speakers, what they have to say, and learn some few points from them. So once again, wishing you all the best. I conclude. Thank you all.
Thank you very much, sir. Next, I request Dr. Ambuja, current KFOG president and head of the Department of Obstetrics and Gynecology at Thrissur Medical College and chairperson of the Fetal and Maternal Committee of KFOG, to kindly say a few words.
Respected President Foxy, Dr. Alpesh Gandhi, senior members of Kerala Federation, patron Professor Badran sir, organizing chair Shekharan sir, Cogs President Dr. Jyoti, the whole team of Cogs, esteemed international guest faculties, and my dear friends. It is indeed a wonderful way of starting the new year with such galaxy of international experts talking to us on high-risk pregnancy and labor. The topics are quite relevant for the practicing obstetrician to improve the quality of care. We are all working towards safe motherhood, and though we seem to have achieved the goal of 2020, we have to go a long way ahead to bring our MMR still low. On behalf of KFOG, I would like to congratulate the Calicut team for organizing such a wonderful virtual meet, with including international faculties who are all experts in their own fields. ICOG has awarded 3 ICOG credit points too. I hope and wish that this academic program gives all of us valuable take-home points in obstetrics. I wish all success for a best academic trait. Jai KFOG.
Thank you very much, ma'am. Next, I request our patron, Professor S. Badran, former professor, Government Medical College, Calicut, to convey his words of wisdom and to bless this program.
Dear friends, words of wisdom will come from speakers. You have selected the best persons for each topic. If a gynec has had no stillbirth, it means she or he has not got sufficient experience. I have never come across any person who can confidently speak any case of preeclampsia or eclampsia. As yet, no ideal treatment is available for improving fetal nutrition. You will be better equipped to treat these scenarios at 7:30 p.m. today at the end of this program. I thank and congratulate the organizing committee headed by Professor P.K. Shekharan, Dr. Jyoti, and Dr. Malaya for their excellent arrangements. Thank you.
Thank you very much, sir. Next, I invite Dr. Subhash Malya, Secretary, Calicut ONG Society, convey his vote of thanks.
Well, I wouldn't take much of time because we just have 5 more minutes to start the program. And I think it's a big thank you to Professor P.K. Shekaran sir for his untiring efforts towards organizing this meet. I think no words are enough to thank him for this. I think he's been the sole proprietor of this whole meeting. Thank you very much, sir, for all the efforts that you have taken. I think there may have been some shortcomings on behalf of our side, but then we still are always learning under you, sir. Thank you very much, sir. I must mention my deep sense of appreciation to Professor Arulkumaran sir, Professor Eyal, Professor James Walker, Professor Gordon Smith, Professor Alexander, and Professor Obrien. Further, we are grateful to the distinguished speakers for their sharing their experience and their expertise in their fields. I'm sure we'll all be, grateful to them after this talk. I also would like to express my words of gratitude for providing an encouragement to Professor Ambijam and Professor Venu sir for all their support. I would also like to be grateful to the chairpersons for their analysis of the subject, all the chairpersons, all the 18 chairpersons. And also I would like to thank the ICOG President Mandakini Madam and the Secretary Dr. Parag Benivali sir for the ICOG points. I am also express my gratitude and appreciation to our beloved Foxy President, Professor Alpesh sir, for coming down to this inauguration and doing the honors. So we are always grateful to you for all the support that you have given us, sir. Again, I would like to take this opportunity to place on record my heartfelt thanks to all the organizers, especially my president, Professor Dr. Jyoti Chandran Madam, all the executive members of my parent society, the Calicut Obstetrics and Gynec Society, the delegates, and also to the support team led by Mrs. Sherien, Dr. Sherien Maldar and Mr. Anil Bajaj from Samvat Life Sciences. They have actually done a lot of work behind the scenes, and I would like to place on record my heartfelt thanks now. I cannot thank everyone enough for their involvement and their willingness to take the completion of tasks beyond their comfort zone. But then I would do injustice if I do not thank our friend Dr. Rajesh, our Joint Secretary Dr. Rajesh and Dr. Sonalika Suresh for all the hard work that they have done behind the scenes. I think I would like to express my heartfelt thanks to them because they have done a lot of work in organizing this. And I wish the whole program a grand success. Thank you, sir. Thank you very much, Professor Shekaran, for all the efforts. I'm sure it will be a great success. So we are on time. We have 2 more minutes to start.
Thank you, Dr. Subhash. Shall we start off with the academic sessions?
I think we can.
I think before we start, ma'am, I would just like Dr. Professor Shekaran to just give a couple of words, sir, because we just have 2 more minutes to start it, sir.
No, we are extremely thankful to our international faculty who have readily accepted our invitation. That was wonderful, and adjusting to the time zone difference and everybody willingly coming with participation in this conference. And I thank all of them once again, and let us hope and see and what they are to offer to us. Thank you.
Okay, so moving on to the much awaited academic sessions. Our first session is on Ctg monitoring in labor by Professor Sir Sabaratnam Arulkumaran. It's my privilege to invite our chairpersons, Professor V.P. Paili, Dr. Sajala Bimalraj, and Dr. Betsy Thomas to chair the session. Professor V.P. Paili needs no introduction. Sir is a past president of KFOG and coordinator of the confidential review of maternal deaths in Kerala and presently consultant at Rajgiri Hospital, Ernakulam. I welcome you, sir. Next, we have Dr. Sajala Bimalraj, additional professor, Department of ONG at Government Medical College, Kozhikode, and joint treasurer of Cogs. I welcome you, ma'am. We have Dr. Betsy Thomas, who is the principal and professor of ONG at Amala Institute of Medical Sciences, Trishur, and past president of Cogs. I welcome you, ma'am. And now request Dr. Sajala to kindly introduce our speaker. Over to you, ma'am.
Very warm good afternoon to all. It's a very happy occasion, and I thank the organizers for giving me this opportunity. It's a very happy occasion for me to be a part of this prestigious meeting today. And we kickstart the proceedings with a talk on Ctg monitoring during labor, which is a topic which is very relevant to us in our day-to-day practice. And to deliver this talk, we have none other than a luminary figure in the field of obstetrics and gynecology, Professor Sir Sabaratnam Arulkumaran who's Professor Emeritus, St. George's University of London. He's also former Professor, National University of Singapore and University of Nottingham. He has been past President of FIGO, RCOG, and the BMA, apart from being Honorary Fellow of various ONG societies from all over the world, including America, Australia, and our very own Foxy too. His prolific volume of work includes more than 300 indexed publications, 30 books, and 200 chapters in many books, many of which relate to our topic for the day, and many of which we, our students, are familiar with in Kerala here. He has also been editor-in-chief of the Journal of Best Practice and Research in Clinical Obstetrics and Gynecology. He has been awarded national awards and honorary doctorates from prestigious universities all over the world. And to top it all, he has been knighted by Her Majesty the Queen in recognition of services to medicine and health services. Over to you, Professor Sir Arulkumaran.
Thank you. Thank you. First, I would like to thank Professor Shekaran for inviting me for this meeting, and my respect to Professor Alpesh Gandhi, President of Foxy, for coming to this occasion, Professor Ambujam, Venugopal, Jyoti Chandra, Subhas Malya for inviting me on behalf of the Kerala Federation. And of course, I would like to acknowledge the patron, Dr. Badran, and also the guest of honor, Rajsekharan Nair, Gopinath, and our chairpersons, VP Piley, Betsy Thomas, know very well, and it's a great pleasure to be with you all here. So I'll start the talk by starting with my slides so that it'll be, okay. So the topic is actually Ctg monitoring during labor, but I'm going to focus only on abnormal fetal heart rate pattern when to deliver. We all learn Ctg monitoring on an obstetrician's point of view. I'm going to look at it from a lawyer's point of view or medical legal point of view. So initially, when there is a cerebral palsy, the presumption is there is some fetal hypoxia which has caused cerebral palsy or neurological injury. Cerebral palsy is a motor disorder which doesn't progress. So there is hemiparesis or quadriparesis or athertoid cerebral palsy. Neurological injury refers to the loss of vision, loss of hearing, which is difficult to attribute to fetal hypoxia. Cerebral palsy can be caused by intrapartum causes like asphyxia, infection, pyrexia. So it is not only asphyxia, and we must remember that Ctg is good in picking up where cases might go wrong with asphyxia, not necessarily things which might go wrong with infection and pyrexia. Now, the court takes the magnetic resonance imaging of the brain of the affected individual as evidence, but the same lesions can be found due to antepartum insult, intrapartum, and postnatal insult. So it need not necessarily be during labor. For example, there is a severe abruption and you do a cesarean section, there will be athertoid type of cerebral palsy and the thalamus hypothalamic nucleus will be affected, which will be the same as prolonged bradycardia in labor. Similar to postpartum, if they have meconium aspiration and don't breathe for some time, it'll give the same shadow on the MRI. But the MRI patterns generally give some idea about the Ctg patterns and will help to identify the lesions. For example, if there is a minor calcification in the brain, that signifies cytomegalovirus infection, and there's a larger calcifications around the periphery, toxoplasmosis. So calcification refers to infection, whereas atrophy and scarring are related to asphyxia. And there are two types identified at term: acute profound hypoxia, which is a prolonged bradycardia or deceleration, and abruption, corporal scar rupture can give rise to these. And that gives rise to thalamic, hypothalamic problems and athertoid cerebral palsy. But if it is repetitive decelerations, what we call as prolonged partial hypoxia, it gives rise to bilateral cortical atrophy and quadriparesis. So these can be identified whether you do the MRI at 5 years, 10 years, 15 years of age.
Pyrexia and infection can cause or contribute to cerebral palsy, so we must keep it in mind. And the prevention is done by better CTG interpretation. Along with the clinical picture, you can't take the CTG interpretation alone because an IUGR baby can get compromised much earlier. There are 6 factors which compromise the baby much earlier: preterm, postterm, thick meconium with scanty liquor, bleeding, pyrexia, or infection can give rise to rapid deterioration with the same CTG pattern. Now, it is always argued that the intrapartum hypoxia has a small contribution, which may be true. This is an epidemiological study by Badawi, which shows 5%. But if you take antepartum and intrapartum hypoxia mixed together, like preeclampsia causing growth restriction, which you're going to hear both topics later, and they are in labor, then they are more likely to get affected. That's why CTG alone is not enough. You have to take the high risk factors and put it together, because the speed of onset of hypoxia, asphyxia will be different. Now, the medical legal background starts from some animal experiment by Myers, who did some work on monkey models. And whenever there was acute profound hypoxia, and they resuscitated the small animals and looked at the brain, they had brainstem and thalamic injury. But if it is prolonged partial, intermittently, if you compress the cord or don't supply oxygen to the baby, and then after some time you resuscitate when the baby is passed out, then it is cortical atrophy, which causes what we call as prolonged partial like asphyxia and gives rise to quadriparesis. Now, if it is without acidosis, then there might be profuse white matter damage. Now, some might have prolonged partial hypoxia followed by acute profound hypoxia. That means there are lots and lots of deceleration, then a sudden bradycardia, then the thalamus, hypothalamus, plus also cortex get affected. These are the babies who will have tracheostomy and might need a gastrostomy for feeding and are paralyzed. So this is a picture of the CTG with acute profound hypoxia. And here the nucleus which will be affected, or the area of the brain, will be thalamic, hypothalamic, and the baby will present with athetoid. That means they have no definitive position. They have jerky movements up and down, as you can recognize people, children walking on the road. And the lesion will be in the thalamic, hypothalamic region as indicated by the white spots here. Whereas if it is due to prolonged partial hypoxia due to intermittent deceleration due to cord compression, the baseline rate starts going up and up. The depth and duration of the deceleration gets greater. And finally, the baseline variability gets affected. And if that baseline variability is affected with decelerations for 1 to 2 hours, then they can get bilateral cortical atrophy. And that can be identified whenever you do an MRI. And as you could see here, the motor cortex is the area which there is scarring, and that'll remain at 5 years, 10 years, and the babies will have quadriplegic cerebral palsy. Now, Henry Hackberg from Gothenburg studied MRI pictures of babies who had cerebral palsy in his district and found that 28% of term children born at term either had bilateral cortical atrophy or athetoid, which is the thalamic hypothalamic injury, indicating that intrapartum causes might have contributed, or immediate postpartum causes might have contributed to the cerebral palsy. Now, as opposed to term injury, the preterm injury is slightly different. This is a publication by Janet Rene, a well-known pediatrician from University College London. And she has studied and she has shown that if it is in a preterm, they don't come with quadriplegic, but they are hemiplegic cerebral palsy. And sometimes they might come with a stroke during labor, some bleeding. So you have to be very careful if it is hemiplegic or monoplegic cerebral palsy, then it may not be at term, it might have been taken place earlier. And usually these ex-preterm children, if there is hypoxia in the preterm, they get ventricular, periventricular hemorrhage and brain atrophy. And these babies, or the ex-preterm children, have periventricular leukomalacia. And I will show you some pictures to show how they develop hemiplegia. This is a CTG picture showing a stroke. So you can see on a CT an area of the brain is affected. And on the CTG, what will happen is the normal CTG, the paper speed is 3 centimeters. The CTG is going well with acceleration. Suddenly there's a bradycardia, and then at that time a stroke must have happened. Then the fetal heart rate jumps from 140 to 160 or 170 and becomes a flat baseline without acceleration. So even if you'd have done a section, nothing could have been done. This is an acute ischemic episode, and the CT scan will show that. And this is another picture, baseline of 140. It's not too bad. A CTG suddenly is jumping to 160, 170. Not a gradual increase, but a sudden with some deceleration. So this is very characteristics of ischemic, either due to hemorrhage or due to thrombosis. Now in the preterm, I mentioned immediately after the hypoxia, there is intraventricular and periventricular hemorrhage. This is on a preterm baby, not on a fetus. And this is what happens. There is a blood clot which is getting organized. Then the blood clot pushes the brain's substance and causes atrophy in the periventricular area. And then finally the blood clot gets absorbed. So because of the atrophy of the brain tissue, the ventricle starts dilating with the blood clot getting absorbed, and the dilatation of the ventricle causes compression on the corticospinal tract. That's why they present with hemiplegia. Both sides are dilated. That might be diplegia of the lower limbs. So the MRI shows you not only whether it's due to infection or asphyxia, but also will show you whether it's due to preterm or term injury. Unfortunately for obstetricians and the midwives, we have only very limited scope of identifying what is going on. And we are postulated for describing a baby to have asphyxial injury. The baby should have a metabolic acidosis, pH less than 7, and base excess more than -12. Early onset encephalopathy after 34 weeks. So this can be picked up by neonatal pediatrician with brain swelling. And finally, they are spastic quadriplegic disconnected or disconnected cerebral palsy. Exclusion has to be done by eliminating the possibility of genetic, infectious, and coagulation disorders. So this is a brain in the neonatal period, in the neonatal unit, where the ventricles are obliterated and the brain is hyperechoic because there has been a recent injury 6 to 12 hours before. And if the baby dies because of this severe asphyxial injury, then on postmortem, you'll get edematous type of brain. So early onset of hypoxic ischemic encephalopathy like convulsions or coma, and also the pediatrician doing a neonatal scan and showing that brain swelling is characteristic. Now, unfortunately, the instrument which used the CTG is a crude instrument. And if you look at NICE guidelines, it says you have to deliver when there is they say needs urgent intervention. If there is a bradycardia, that's very obvious if it is prolonged bradycardia and goes on for 9 minutes. But if there's an abnormal feature associated with current fetal acidosis or imminent rapid fetal acidosis, then we must deliver. So what are these abnormal features? This is what we are going to look at during my lecture. We'll start with the baseline. What tells us the baby is in good health are what we call as accelerations. That is a function of the somatic nervous system. When the baby moves, there's an acceleration. And baseline variability is the bandwidth, putting a line on the top and the bottom, that should be 5 to 25. Sympathetic pushes it up and parasympathetic pushes it down. So this baby has a good somatic and an autonomic response. It has an active phase, then goes into sleep. And if you get 2 accelerations, we call it reactive trace, 2 accelerations within 15 minutes. Should be 15 seconds in duration, and from the onset to the apex should be 15 beats. So this baby is not hypoxic. And the opposite of that, decelerations, means there is some insult. It doesn't mean there is hypoxia. So this baby is not hypoxic and there's no insult going on. And Richard Beard, who did a lot of work, as well as Fred Kubley and Richard Paul from America, they all showed if the baby has accelerations on the trace, not a single baby is acidotic. Or if the baby has tachycardia and decelerations and reduced variability, 55% might be acidotic. But this is a function of time. The more you leave them, the more babies will get acidotic. I'd like to acknowledge Philip Steer, who gave me this slide. Now, the first response is reactivity, second is cyclicity. When the baby matures, it has a behavioral pattern of active, active sleep. So in other words, it goes to a quiet epoch and an active epoch. If we don't see this quiet and active epoch, that means the baby's brain might have been damaged already. So if you see only sporadic acceleration, that means the baby is not hypoxic, but there is some other injury which has taken place. So the active and quiet epoch is called cycling. So for us at the beginning of labor to say this baby is in good health and is unlikely to be acidotic and no injury has happened, we must look at two features, reactivity and cycling. This goes on from the beginning of labor towards the end of the labor. Unless you give pethidine, it gets reduced variability for about 3 hours, and towards the late first stage and second stage, it gets reduced. Now, we're all worried about decelerations, and the commonest is variable due to cord compression. And what we have to remember is what we call as a complex or an abnormal deceleration, which means not only a simple variable as you could see, but there is an additional late component or a late recovery or a post acceleration or post tachycardia, then it is something not very good. Now people get worried about it, but very simple thing to do is, this is from Caldera-Basia's work. If you take a contraction and draw a line at the beginning of the contraction and the end of the contraction, if the deceleration falls within these two lines between the beginning and the end, that baby will not run into any problem because it will have enough time at the baseline. As the baby gets hypoxic, the return takes longer time. As you could see, the return is, if you draw the second line, it is cutting that line. And not only it is taking a longer time and proceeds beyond the contraction, but also what happens is the interdeceleration intervals get shorter and shorter. And at the same time, the heart rate goes up and finally the variability gets reduced. Now there is no CTG classification guidelines which talks about interdeceleration interval or increase in depth and duration of deceleration or the progressive decrease in variability. So we need some sort of machine learning procedure to find out these changes. But if you can remember that when the fetus gets hypoxic more and more, the deceleration increases in depth and duration, interdeceleration intervals get shorter, rise in baseline rate, and finally reduction in variability. And once the variability is reduced 1 to 2 hours, the baby will get acidotic. Now we have this idea about defining the CTG by using mnemonics like Dr. C. Bravado define the features, baseline rate, variability, acceleration, decelerations. But unlike doing a blood test for preeclampsia, for example, what was the liver enzyme and so on yesterday to today, we are not really looking at the changes in baseline rate, variability, decelerations with progress of time. So we had to really change this, and it is difficult to manually interpret unless you really look for it. But also you must identify the pathology, what is causing the problem, and do a plan of action. So I would like to propose 4-stage types of asphyxia, which we look at medico-legal, whether it was acute distress, which has prolonged bradycardia less than 80, where the pH in 50% of the babies can drop by 0.01. Subacute, where there was prolonged deceleration lasting for 90 seconds to 2 minutes, but it comes to the baseline only for 30 seconds, like immersing somebody for 90 seconds, keeping the baby for 30 seconds, immersing 90 seconds. That baby will get hypoxic and acidosis will build up by 0.01 every 2 to 3 minutes. Long-standing or chronic hypoxia is where there's hardly any accelerations or variability, and there'll be shallow decelerations. And this baby will have telltale signs with reduced fetal movements, bleeding, infection, something. And the commonest is gradually developing hypoxia, where there no deceleration, then it starts appearing and it gets deeper and wider. Heart rate starts going up and the interdeceleration interval gets shorter. And finally, the baseline variability gets reduced. Now, this type of trace will take 1, 2, or 4 hours before the baby gets acidotic. That depends on the background picture of the baby, whether there was growth restriction. There are a number of cases described in this book called The Crimson File, written by Tessa Mitchell, which is worthwhile reading. And so I'm going to go through this profound hypoxia. This causes athetide or dyskinetic type of cerebral palsy. Now, how long should it be depends on how lower the heart rate is, because if it is at 80, in 10 minutes, it has 800 circulations. If it is 50, in 10 minutes, it has only 500 circulations. So it's going to miss from 1,400 to 500. The baby is going to get acidotic quicker. So the actual rate, the duration, and the cause, because if it is abruption or a scar rupture, there's not enough blood going to the uterus, so it is going to get acutely compromised very quickly. And this was studied earlier in 1985 by myself, Ingamasan, and Ratnam in Singapore, and we said that if the heart rate is less than 80, then the babies will get compromised, and if it is more than 10 minutes of bradycardia, then the babies are likely to get acidotic. And also, if the baseline variability is markedly reduced. Now, similar studies has been done by others about terminal fetal heart rate deceleration, and they have also described the rate of decline. And the latest study was from Tiva Leung and his group from Hong Kong, and they also estimated the rate of fall is 0.011 per minute. So in other words, in these cases, you have to deliver the baby in 15 to 30 minutes. Just an example, this is a previous cesarean scar woman in labor. And at 14:20, there is a sudden drop in the heart rate. She's on oxytocin. So instead of delivering because normally the head is 3/5, if it is 5/5 now, it is a scar rupture. So instead of that, they were using ultrasound, trying to get the heart rate back. By the time they picked it up, it was a problem. It was 14:55. 35 minutes had gone. And when they went in, the scar has ruptured, poor Abgasco, baby developed grade 3 HIE and cerebral palsy. So these are things which could avoid if you can pick it up early. Now, specifically with uterine rupture, the duration is shorter. You have to act, and this is from Richard Paul's unit saying, if after 18 minutes, there is a gradual increase in the incidence of asphyxia. So if you can manage to deliver within 18 minutes a scar rupture, you are better off. Now, the second is subacute hypoxia, where there's prolonged deceleration. This is more common in the second stage of labor, late first stage, probably because of occult cord compression. The duration lasts for 90 seconds and the recovery is 30 seconds. And there again, there are papers which says the total deceleration area demonstrates superior predictive ability for acidemia rather than the traditional ACOG or the NICE classifications. So this is actually the late first stage, second stage. The deceleration suddenly becomes broader, that is lasting for 2 minutes. It comes for 30 seconds. So it's like immersing somebody underwater for 2 minutes, 30 seconds, and immersing again. The person doesn't have the time to reorganize or breathe out the carbon dioxide and so on. And when that happens, the variability becomes saltatory. And every 10 minutes, the pH will drop by 0.05. So if you think it's 720 here, by 20 minutes, 10 points would have dropped. 60 minutes, 30 points would have dropped. It would have come to 6.9. And then at 1 hour, 0.1 hour, it becomes bradycardic. So the decline will be 0.01 every minute. And by the time they delivered, the baby's pH was 6.79 or 6.8 as predicted. The base excess of -19. So this baby, because it has prolonged partial hypoxia and a terminal bradycardia, had both white matter injury as well as thalamic hypothalamic injury. The third is the gradually developing hypoxia, where I mentioned the heart rate goes up and up with deceleration getting deeper and wider and the interdeceleration interval getting shorter. So here you look at the clinical picture, the parity, dilatation, rate of progress, and then manage, because the same CTG in a parous woman who is at 8 centimeter, you would leave her alone. If she's 3 centimeter nulliparous, you might do a cesarean section. And there again, the most important feature is the baseline variability. Significant fetal heart rate parameter is minimal absent variability for 1 hour in conjunction with late decelerations. So if you take two patterns, this has variability present despite late deceleration, but this one, the variability is absent. So this baby is going to run into trouble unless the baby is going to be delivered imminently. These are not early, these are variable deceleration. So whoever is looking after don't know how to interpret the CTG. But I just want you to look at this baseline rate of 140. Accelerations are still present, variability is still present. So the baby is not acidotic now, but there is a cord compression. And this is in a mother with sickle cell disease who had IUGR baby. an hour later, the decelerations become more frequent and the depth is increasing and the duration is increasing. So they put on the side and gave us some oxygen. And they decided to give IV fluids 1 hour later and do a pH after epidural, which they did, and it was 7.27. So by this time, 4 hours had gone from the time of admission. But with this trace, she was only about 6 centimeters in a primary. She's unlikely to deliver. A decision could have been made. But they looked at 11 o'clock, so it's 23 hours, and didn't do anything. And they missed at midnight, and 1 o'clock they came, it was 170 and hardly any variability. Now, if you don't deliver this baby now, the baby is likely to run into trouble. And you can see the interdeceleration interval for many of these is much shorter compared to the beginning, and this baby will not stand a chance. So nothing was done for 1 more hour. The baby gives up and the heart rate comes down, and they did a forceps here, and it was a stillbirth. So this is in the US, they call it Horn's stepladder pattern to death. So it goes up and up, remains in a plateau with absent variability, and then comes down. So there's plenty of time to have intervened. And the fourth pattern, which I'm talking, is long-standing hypoxia. You should see these shallow decelerations with absent variability. These babies will have a clinical history of bleeding, absent fetal movement, thick meconium infection, and so forth. So you have to be very careful if things don't change within 90 minutes or 60 minutes, because each contraction is going to cut down the blood supply, but the baby's brain is blunted and you won't be able to do anything better. There won't be any more deceleration. This is 1 hour later, no change. 2 hours later, although there's no change in the CTG, hypoxia is continuing and the baby is getting metabolic acidosis. And finally, it gives up at this point. So if there is meconium, if there is absent fetal movement, if there is infection, if there's bleeding, and within 60 minutes, if there's no change and there are shallow decelerations, one has to take action. And finally, a little bit about other variant called the baseline variability becoming saltatory, some work done by Julian Parra. So this is actually the trace in a case, and this is midnight now, and they decided to do an epidural, but did not take any monitoring precautions of the baby. And when the head is deep down, it compresses the uterine vessels, and there's a greater chance of hypoxia. When they are recovered and put the monitor on, it's a saltatory pattern with decelerations. And this should have been noted, and they should have delivered. But before they could do anything, the heart rate became lower. They wanted to deliver. It was an OP position. Cervix was fully dilated. And they did section because OP and high, but the baby had a neonatal death. Saltatory pattern is quite important. Infection is another which you can't really prevent all problems, but you should try. This is a case with already a tachycardia 160, but since the trace doesn't show any deceleration, there's no hypoxic component. And this is a fetal ECG, which also shows there's no problem. A couple of hours later, the heart rate has gone to 180, and then it becomes some decelerative. Then 190, it has gone. And because there were no decelerations and the ECG was normal, they left her alone because there was no hypoxic element. And the ABCAS and the pH was normal. It doesn't show any hypoxia, but the baby developed seizures in 9 hours. And neonatal encephalopathy grade 2. So this is purely due to infection and not to hypoxia, asphyxia. And here, if there is meconium, if there is failure to progress, and if any other problems, then we had to deliver rather than jumping on every case. And it has been shown that in animal experiments, if you give saline as opposed to lipopolysaccharide, because the bacterial wall proteins and then cause asphyxia and then resuscitate, those who had lipopolysaccharide has greater damage. And epidemiological studies have shown if there is maternal pyrexia, there is increased incidence of neonatal encephalopathy, and also where there is increased incidence of cerebral palsy. And similarly with hypoxia and proper CTG interpretation is necessary. In the second stage, this is a bad trace, and you can see the vaginal examination, it's a heart rate of 150, and then suddenly they readjusted the trace, it becomes 120 with accelerations corresponding with the contraction. That is not very good. That means it might be the maternal heart rate, and it has been shown by experimental design the contraction in the second stage is associated with maternal heart acceleration. Once the baby is delivered, it becomes a straight line. And here, the deceleration suddenly become accelerative trace. That is where it has changed from fetal to maternal trace. And if there is double heart rate, especially in the late second stage of labor, you have to be very careful, because you can think one is fetal, one is maternal, but this is fetal and this is also fetal because the machine is doubling up. And they did not recognize and left it, and this outcome was very poor. So I mentioned about fetal behavioral cycle, and this is what happens when the baby is already injured. You get sporadic acceleration, but the baby is not hypoxic, but it is has suffered an injury before. So how can we reduce all these? I think you have to think about maternal position, giving IV fluids, tocolysis if necessary, and oxygen administration for a short time is okay. Long time is not very good. So I started with cerebral palsy, can be intrapartum causes, and it relates to asphyxia, to the observed injury. And nowadays people are trying to do late cord clamping, whether it's a possibility, but postnatal resuscitation is an important component, and new treatment modalities, which are like head and body cooling, is also important. So continuous learning is important to interpret the CTGs, like master classes and lectures. Alternatives should be tried, like fetal blood sampling. Newer modalities like FM alert and infant study, which was done in the UK, did not show any improvement. So we had to improve from what has been done so far by clinical research and the future. And the CTG ECG also hasn't shown any improvement. So machine learning might come in to assist in the future. Thank you very much for your kind listening.
Thank you, Sir Arulkumaran. That was an exhaustive talk on the CTG and subnormalities. And now I request persons, Dr. Pairisa, Betsy Madam and Sajila Madam to give their comments.
Thank you, Arul. So nice to see you, even though it's virtual. Yeah. And you have brought in new points now. Worrying, in fact, because you said that we can trace the lesion to the time when the asphyxia happened by studying the brain of the baby. So that is, of course, that has been an information there. I hope I am audible. Am I?
Yes, sir. Yes, sir.
Yes. Yeah.
From the practical angle, Arul, what for most of the audience, a point which I thought we have to convey is, now CTG is very extensively used in our country, and interpretation of CTG, as you showed the fine points, is so important. But very often a practice is that people stop doing CTG when they think the patient is about to be delivered. So they shift her to the second stage of labor and wait for the delivery, which can take minutes or even hours. And during that time, CTG may not be taken. And that's a time when most of the time heart complications or head compression can lead to bradycardia, prolonged bradycardia even. So that I thought was a message we have to take. But it was quite reassuring to see your Badawi slide that you showed. Only 4% of the problems are intrapartum, and most of them are antepartum. Am I right in the way you showed the slide?
No, I think 25% are antepartum and intrapartum. 4% is purely intrapartum. So in other words, if they have growth restriction, severe preeclampsia, other problems, and then the mother comes in labor, then they are more likely to run into trouble. So in other words, the babies or baby, high risk baby, then with a shorter segment of a post affected compared to no risk factors, then it will take a longer time. That's why the clinical factors had to be taken into consideration when interpreting a CTG.
And you emphasize the importance of the interdeceleration interval and what the baseline is like. Thank you for that. There's a question from Dr. Jyoti. What percentage of the CP could be due to intrapartum asphyxia?
Well, the not purely due to intrapartum asphyxia, based on Badawi's study, as well as I showed Henry Hagberg's MRI studies, at least about 25% have a combination. So in other words, 75% or so are due to antepartum factors like infection, genetic, etc., or congenital malformations. 25% have some attribution to intrapartum factors, although we think it's 5 to 10%, but if you combine antenatal risk factors, then we had to, so if there's a baby with IUGR, then we had to intervene much earlier with a given CTG. And the same was shown in the infant study. When the clinical factors were not included properly, then the outcome was poor.
I leave it to Betsy and Sajala. You have anything to clarify or bring up?
I would I think probably we need to emphasize the knee-jerk reaction to the first deceleration that we see. Should not be there. We should give a little more time to interpret, see how it progresses, take into account the clinical picture before we actually decide to go and rush ahead with a cesarean section.
Yes, you're absolutely right, because deceleration tells us there is a cord compression or reduced retroplacental reserve or something, but it doesn't tell the baby is asphyxiated. So what shows whether the baby is hypoxia or not is the rise in baseline, reduced variability, and so forth. Deceleration tells us a mechanism. So you're right, people do cesarean section too early sometimes.
Thank you, Arulkumaran sir. Every time you deliver a talk on CTG, something new comes up. Like earlier it was fetal scalp pH, then fetal ECG and stand, and this time MRI. Sir, just in one of the slides you talked about acute ischemic stroke. Like, is it like even the normal babies can have an ischemic stroke in labor, either thrombotic or a hemorrhagic?
Yes, so they can have, it's extremely rare, but if something happens, then you should be able to look at the CTG back again and ask them to do the relevant investigations. So as I mentioned, the baby's trace is normal, then a bradycardia or slight deceleration, then suddenly the heart rate jumps by 15 to 20 beats and remains static without any variability. That means there is an acute injury which has taken place, most likely a stroke of either bleeding or thrombosis. So you can do a CT scan and pick it up. And similarly, if there is non-cycling trace, a sporadic deceleration without an active quiet epoch, then again, that suggests there's a possibility of an injury. I can just relate a short story. There was a senior obstetrician who did a vacuum in Singapore. Baby's Abgas was 6 and 8, but then 6 hours later, the baby started fitting. And they said there must be infection. They did a lumbar puncture and found blood-stained CSF. So I said, well, this doctor had done the vacuum, and this is what happened. And so they sent the trace, and from the very beginning, from the very early on, even before labor started, the trace showed sporadic acceleration, not a cycling. So I said this bleeding was there from before. So they had to investigate for vascular malformations, which has given way, and that was what they found. So I think you have to look at it very carefully and also add some investigations like MRIs to support your views.
So you mean to say the stress of labor can induce stroke? Like, is it a factor?
Not the stress of labor. They probably have some vascular malformations, which is added on or precipitated by stress of labor, because the traces I showed were in the first stage, but it is also known by some work by Barry Schifrin that prolonged labor in the second stage, prolonged second stage, and prolonged decelerations, and suddenly, so you find mother is pushing, there's a deceleration, pushing deceleration, and then you apply the vacuum, and when you look at the trace beforehand, even before you applied the vacuum, those decelerations had disappeared suddenly, and then it has become a straight line, and after which you have applied the vacuum. So in other words, injury has taken place just prior to your application and not related to the vacuum. And then you do a CT MRI and you find focal hemorrhagic lesions. So you have to investigate that very carefully. What happened to the trace before you applied the vacuum or forceps? Was it decelerating or was it flat after decelerating? And then what CTG MRI shows will give you some clues, yeah.
I would like to highlight the intrapartum resuscitation, like, giving oxygen you mentioned partially, but changing the position, stopping oxytocin, and terbutaline, what the role, and it's not a very widely practiced step here.
Yes, well, the practice of terbutaline, in fact, the paper I showed was about terbutaline and prolonged bradycardia from Singapore, because we had 25,000 deliveries in one unit with 2 operating theaters. So the decelerations are going on and we want to deliver, but there's no theater space. And every deceleration is going to reduce the heart rate and cause more and more of hypoxia. So the idea was to give the terbutaline 0.25 milligrams and abolish the contractions, so the heart rate will come back to normal, so the baby won't deteriorate hypoxia, because even with prolonged decelerations, even 20-30 minutes can cause severe problem of asphyxia. So I think there is a role for tocolytic agents, and whether it's prolonged bradycardia due to tetanic contractions, or even with normal contractions, if there are prolonged decelerations, there's no contraindication. The only caveat is if you do the delivery within 20 minutes, then they might have a relaxed uterus and can have a postpartum hemorrhage, which can be managed by propranolol 1 milligram. But most of the time, by the time we take the patient to the theater, 15-20 minutes are gone by.
Thank you. I think we have to call it off.
There's a query like a routine MRI, will it pick up all antenatal events? Somebody has posed this query.
Well, if the baby has a lesion or cerebral palsy or a problem, neurological problem, then they will have to do the MRI, and that might shine some light on what has gone on, because there might be problems with infection, congenital malformations, and so forth. So if we think the baby was born in good condition, but then deteriorates, then there's a high possibility there has been some antenatal risk factors there.
Any time frame, sir, when this MRI will be done postnatally?
So it can be done anytime, whether it's 10 days, 20 days, 1 year, 5 years, because the scarring will remain for life. So, and also the calcification due to infection will remain for life. So you can't change it. So MRI can be done. That's why the cases are coming up after 10 years, 15 years. They do an MRI, they find something, and they come back. That's why my approach to this lecture was looking at the medical legal point of view and focusing backwards rather than obstetrician's point of view and focusing forwards.
You frightened us.
No, not at all, not at all. I'm sorry if I had done that, but I think it is.
Yeah, that's a fact. Okay.
Just reassuring, all the hemorrhage which is picked up in the postnatal period need not be because of the instruments what we put. It is really reassuring.
Absolutely, yeah.
I think we might have to call it off because there are others lined up. And thank you, Arul, for this wonderful update. Especially
thank you very much.
Yeah, bringing it very practical points. And thank you very much.
Thank you very much. I'll listen carefully now for the other lectures. Thank you.
Thank you, sir, Arulkumaran sir, Betsy madam, Paili sir, and Sajna madam. It was a fantastic session. Now we'll move on. The next session is on the screening for fetal growth restriction by Professor Gordon C.S. Smith. The chairpersons for the session are Dr. Beena Guhan madam, Dr. Bijoy Balakrishnan, and Dr. M. Venugopal. Beena madam is the Professor, Department of OBG, Calicut Medical College, and head of the Fetal-Maternal Unit of IMCH. She was the past president and past secretary of Calicut ONG Society. Dr. Bijoy K. Balakrishnan is a specialist lead consultant, Fetal Medicine Unit, CIMAR, Kochi and Edappad, and is the executive member of Fetal Cardiology Working Group in 2015, HOD Department of FNB in High-Risk Pregnancy Perinatology in 2017. He is a peer reviewer for British Journal of Obstetrics and Gynecology. Dr. M. Venugopal is a consultant ART specialist at IRMC IVF Fertility Center, Thrissur, Palakkad and Salem. Is the Honorable Secretary General, Kerala Federation of Obstetrics and Gynecology. Is the Secretary, Kerala Chapter of IFS and Convener, Andrology. I now request Dr. M. Venugopal to introduce the speaker, Professor Gordon Smith.
Thank you very much. It's my proud privilege to be able to introduce to all of you Professor Gordon Smith. Professor Gordon Smith is professor and head of department Obstetrics and Gynecology at the University of Cambridge. He is clinically active as consultant in maternal fetal medicine at Rosie Hospital, Cambridge. His main area of research is on screening and intervention of fetal growth retardation using biomarkers and serial ultrasonography. He has 458 publications to his credit. It's my privilege to introduce you, sir. Over to you for your talk.
Right. So can you hear me okay?
Yes, sir.
Yeah. Right. Okay. So I'll just share my screen. And okay, can you see the full slide as a full screen? Okay, so
it's 2 slides.
2 slides. Okay, I'll see if I can.
So Smith, can we go for the?
Okay, I'll just. It should be possible to.
Mr. Bajaj, please guide him.
Yes, sir.
Yeah, I'm just wondering about, I tried to share this, which I think is PowerPoint itself. I'm really just looking for my desktop, but it doesn't seem to be appearing there actually.
Sir, first open your presentation, then click on this green color button, share screen. Yeah, now it's
right.
coming. Yeah.
So kindly go for the full screen.
Okay. From beginning, okay. And can you see it now as a single slide?
It is single slide.
Great, okay.
But then again, we would like you to go for the full screen.
All right, okay.
Could you go for the slideshow?
Has that worked?
On the bottom, sir.
No, it's on the top also it is there.
I'm now on my full screen thing. Sorry about this. We did a little trial run and it seemed to work okay then.
That's okay, sir. No issues, sir. No issues. Please take your time. No issues.
So. Oh dear. Right. So I want to. What I was hoping was it would allow me to screen share my desktop, the whole thing, rather than. So I'm guessing yours.
Yeah. Have the slideshow. You are going near that only.
Yeah. So it's just when I go into slideshow, instead of being a single slide, it seems to be the double slide.
No, it is.
So may I guide you?
Yeah, please.
Yes. So on the right side, you can come down on your screen, sir. After the comments section, that is the right lower bottom. Yeah, you can see the full screen. Just next. Yeah, just to the left of it. Yeah, just to the left of it where you right now.
That's
the full screen.
Yeah, I think that's my Wi-Fi thing actually. I don't.
No. Before
oh
that,
yeah. Got you. Yeah.
Next.
So,
Next.
There we go. Yeah.
Next.
Is that still on 2 slides?
No.
Yeah, the one after that, sir. You did click on the one after that.
Okay,
the one with a cup of wine. Looks like a cup of wine.
Yeah, I've got that's one slideshow. It says, but I think it's just doing the same thing.
Are you on full screen, sir?
It's coming. Now it is 2 slides. Now cut the other one. It's 2 slides again.
So once again, sir, on your pin, so just after the pin, the fourth icon after the pin.
Sorry, I didn't catch what you said just there, sorry.
So just below this, yeah, come down, sir.
So what I'm looking at is just the first slide as full screen. I don't see, there's nothing else on the screen for me. I'm on full screen on my monitor.
Yeah, it is 2, sorry.
But you're seeing 2 slides.
Yeah. We'll go ahead, sir.
Yeah, we'll go ahead, sir. We'll go ahead, sir. No issues.
Okay, so sorry that it's not ideal. I'll go through as best I can. So sorry about we'd had a sort of technical run through which seemed to go better than this. I can't seem to share my desktop, but anyway, we'll carry on. So I'm going to give you a talk on our work on developing new methods for screening for fetal growth restriction. And screening for fetal growth restriction is really part of our basic antenatal care. And I'm going to try and just illustrate what are the problems with what we do at the moment, and how can we think about potentially developing better ways to screen for this condition. We work with industry, with Roche, Illumina, and then with other industrial supporters in terms of other areas. I think this partnership's actually really important, because when we come to try and implement things into routine clinical care, we need to have assays that are conducted in appropriate equipment and appropriate level of reproducibility. So that collaboration with industry is purposeful. I'll illustrate the problem with a clinical case. Not somebody that I looked after, but somebody who I met after they had this event. Sophie and Alessandro are a couple in London, prosperous, healthy. Sophie was in her first pregnancy with no significant past medical history. She was well at her booking. She was a normal examination. She went through a pregnancy being told by a midwife she was having a textbook pregnancy. She attended the maternity assessment unit in late gestation, near term, just feeling something wasn't quite right. And when they assessed her, the fetal heart was absent. She had labour induced, and 2 days later, her baby was stillborn, weighing 1.45 kilograms. And so what we have here is a plot of the normal range of weight, and the red spot is Sophie's baby at Liberty, who was about half the size she was supposed to be at that stage in pregnancy. And what this illustrates...
Can you just press on display settings?
Sorry?
Can you just press on display settings?
Okay, sorry.
Display settings and put it in one at the top, which is coming. Can you change that? Yeah, now it's better.
Should we just keep it at that then?
Yeah, we'll continue the same, sir. We'll continue the same.
Okay, that's fine. So this is the birth weight of a baby, illustrating the baby was about half the size that she should have been, but Sophie had had all the sort of routine antenatal care. This might be the way to improve the size of the picture. She'd had all the antenatal care, but this diagnosis of the baby being approximately half the size she should have been had been missed through her antenatal care. So what do we do? What did she have at that time to try and detect this complication of fetal growth restriction? Well, the screening in the UK for low-risk women is based on the NICE guideline for antenatal care. And the sole positive recommendation in relation to screening low-risk women is serial measurement of the symphyseal fundal height with a tape measure. Now, the NICE guideline considered the possibility of universal screening using late pregnancy ultrasound, but they cited a Cochrane review of meta-analysis of 13 randomized controlled trials, including 35,000 women, which failed to show any evidence of benefit. And they recommended research on the diagnostic effectiveness of ultrasound in low-risk women, but said that ultrasound should not routinely be performed. So looking at this Cochrane review, it was 13 studies with 35,000 women, and made a very specific and sort of a positive conclusion about a negative result. Said that there is no evidence that routine late pregnancy ultrasound confers benefit on the mother or the baby. So this is a negative statement, but framed in an emphatic way, suggesting there's really no doubt left around it. And that's why there's this recommendation not to perform universal late pregnancy ultrasound. And if we look at the meta-analysis in relation to perinatal mortality, we have a series of 8 studies where this outcome was assessed. They include a total of over 30,000 women, and the use of universal ultrasound was associated with the relative risk of perinatal death of 1.01. with confidence intervals of 0.67 to 1.54. So you could look at this and think, well, this is really fairly unambiguous. There's nothing to suggest that scanning every woman in late pregnancy is beneficial. This is a paper I published earlier this year, rather in 2020, in the British Journal, where I went through that Cochrane meta-analysis. And there's a number of elements of the meta-analysis that I think we really need to look at and think, how confident can we be that this is a negative conclusion? So there were 8 studies looking at perinatal mortality, but they all used different ultrasonic assessments, and they all performed their scans at different gestational ages, some in the early 3rd trimester, some in the late 3rd trimester. One of the big studies actually only evaluated placental maturity, whereas most of the other studies made some form of assessment of fetal biometry. So one of the questions is, how can you combine a whole series of different diagnostic tests performed at different gestational ages into a single analysis? One thing that all 8 studies had in common was that none of them were preceded with good evidence of diagnostic effectiveness. So they hadn't gone into a low-risk population and evaluated the performance of the test before performing the randomized controlled trial. Crucially, none of these studies coupled the screening test to intervention. So they did the scan, and then the result was revealed, but without being coupled with any specific package of care for a given finding. Further thing is that although 35,000 women seems like a lot, a sample size calculation indicates that using even very optimistic assessments of screening performance and intervention, the sample size 5 times greater would be required in order to say whether there was an effect on perinatal death. So rather than this firm conclusion, ultrasound has been shown not to be effective, I suggest there's a different conclusion, and that is we don't know. We can't say one way or the other. Maybe universal ultrasound helps, maybe it doesn't. We can't answer that question based on the current data because of these issues. Now in France, they performed they implement, I'm just seeing somebody's raised their hand, I wasn't sure if that was something about the technical side. The French implemented universal ultrasound as part of the routine clinical care in the absence of direct evidence that it was beneficial. And a really key paper published in the British Journal about 5 years ago looked at the outcomes of small babies that were actually born small. And what they found was that when the baby was actually born small, those that were detected by the antenatal ultrasound, there was no obvious benefit compared with those which had been missed. But the really key thing was there was strong evidence of harm to false positives. So if the baby was actually normally grown, but the ultrasound had wrongly indicated that the baby might be small for gestational age, there was increased rates of morbidity due to induced premature birth. And really this is, when we get an ultrasound diagnosis, I suggest there are 4 possibilities of what we might be looking at. The first one is we see the baby small on scan and we've got it completely wrong. This is a healthy baby that's normally grown. Second possibility is we've got it partially right. The baby is small on scan, but actually it's a constitutionally small, healthy baby. Third possibility is that we've got it more right again in that the baby has fetal growth restriction. However, the natural history of the condition is that knowing that diagnosis and intervening wouldn't actually change the clinical outcome. And then we have our final group, which is fetal growth restriction with complications. And this is the group where there's actually the potential for improving the outcome based on intervention. And this is the group that we're actually really interested in detecting. Now, the big question is, how many of these babies are there for the rest of these? Because that's what's going to determine the effect of screening and intervention. And that's a statistic I'll show you later on. So I'm going to step back and think about this question, and we'll start you with an analogy around how do we plan, how we intervene. So the analogy is that you're walking home and you see that there's a house on fire. There are 10 people on each floor of the house. The stairs are engulfed in flames, so people can't move from one floor to the other. You're alone and standing outside the house and you have a large axe. What do you do first? Well, a sensible person breaks down the front door and lets the people out from the ground floor because it's easy, and the people escaping by the front door are likely to survive. A maternal fetal medicine specialist, through force of professional habit, ignores the people on the ground floor, scales up the drain pipe, smashes open the top window, and throws people out the top window, where half of them die on impact and half of the survivors are severely impaired. So what's the background to this analogy? This is fetal growth restriction. This is extreme preterm birth. This is moderate preterm birth, and this is fetal growth restriction at term. And as maternal fetal medicine specialists, we're all obsessed on that early onset IUGR, where 50% of the babies delivered preterm may die and 50% of the survivors severely impaired. And what we're tending to do is to ignore the potential much more potentially preventable morbidity and mortality that we see at term. So when we look at the risk of perinatal death at term, we see the same associations with fetal growth. This is work that we published from Scottish data. We have on the x-axis the birth weight percentile, babies less than a third, between the 4th and the 10th, 11th to the 20th, etc. And what we see for antepartum stillbirth, where the baby dies before the onset of labour, and then intrapartum complications and neonatal death at term, in both cases there's an excess amongst the small babies. And for antepartum stillbirth, really quite a significant excess, but an 8-fold increase in the risk of death in the babies less than the 3rd percentile. So there is a problem with fetal growth restriction at term, and this would seem to be a reasonable place to start to trying to evaluate, can we perform screening and intervention and prevent some of these adverse outcomes.
Hello.
So our goals have been to develop better methods for screening for fetal growth restriction at term, and then to evaluate these methods in a randomized controlled trial of screening and intervention. And the idea is, if we can show proof of principle that this can be done safely at term, we can then move back into earlier gestational ages and see whether we can improve outcomes through screening for fetal growth restriction earlier when the risks of intervention are greater. So we conducted a study called the Pregnancy Outcome Prediction Study. The protocol was published over 10 years ago. The rationale I outlined in a review in PLOS Medicine, now getting on for 10 years ago. And then we published the first paper arising from the study in The Lancet in 2015, and a series of papers since then. And this study is trying to provide a framework for identifying new ways for screening low-risk women, particularly those in their first pregnancy. So we recruited women at the time of their first scan. We saw them for their mid-trimester anomaly scan, and we saw them for purely research visits at 28 and 36 weeks of gestational age. When the mother delivered, we systematically sampled the placenta, and then we obtained the outcome for the baby through review of the case notes. At each of these visits, we obtained blood for serum and plasma. At the last 3 visits, the 20, 28, 36, we performed full uteroplacental Doppler. And we managed to follow over 4,000 first pregnancies from that booking scan and blood test all the way through to delivery and collection of placental samples. So what we're left with is a very rich resource to try and identify better ways of screening. We have the mother and baby with the research data, which we've collected, the clinical data around ultrasound routine clinical care, and then biological samples of DNA, placenta, and maternal blood. And those have been a large part of the basis for developing studies to address our aims. So what we're going to just do quickly today is to address a simple question, which is, does combining ultrasonic assessment of fetal size with biochemical tests in later pregnancy result in better prediction of term fetal growth restriction? And this is going to report the results of 2 papers, one published in Lancet Child and Adolescent Health just over 2 years ago, where we looked at the ultrasound plus the S/1 ratio, and then the second published last year in Nature Medicine, where we're trying to develop completely new biomarkers for fetal growth restriction. So first of all, the Lancet paper, and the biomarker we looked at was a thing called the S/1 ratio. So S/1 and PLGF are both proteins produced by the placenta. PLGF is actually produced by other tissues as well, but S/1 is a thing called the soluble Fims-like tyrosine kinase receptor 1, and it's released from the placenta when it's hypoxic. And PLGF is placenta growth factor, which is a protein that's important in the stimulation of blood vessel development and in the sustaining of a healthy endothelium. Summarizing a huge amount of work, essentially, a sick placenta is characterized by high levels of SFLT1 and low levels of PLGF. And a ratio of these two proteins of greater than 38 is regarded as elevated and is now used as a rule-out test for preeclampsia in women who present with symptoms. So if a woman actually has preeclampsia, it's quite unlikely that she has preeclampsia but has a normal SFLT1 PLGF ratio. So if she presents with suspected disease, this blood test can help triage her for, does she need to be admitted? Do we need to think about induction of labor, or can she be sent home? And this is currently in clinical use in the UK in preterm preeclampsia. And our placental studies have indicated a lot of similarities between the preeclamptic placenta and the fetal growth restriction placenta. So what we set out to do was to see whether the SFLT1 PLGF ratio could potentially improve our ability to identify a true fetal growth restriction amongst our small for gestational age population. So we had in the POP study just over 3,700 women who were seen at 36 weeks of gestational age, who had an ultrasound scan and who had a measurement of SFLT1 PLGF. And importantly, these results were blinded. So we'd done these for the purposes of research. These hadn't been done for the purposes of routine clinical care. So the results of the test didn't subsequently affect clinical management. And that's really critical, because revealing the results of experimental tests can result in a whole series of biases. So we defined screen positive either as a small baby on scan, an elevated SFLT1 to PLGF ratio using a Roche platform, or the combination of both a small baby and an elevated ratio. And we weren't just interested in having the outcome of a small baby. We wanted that complicated fetal growth restriction case. So our outcome was defined as a baby less than the 10th percentile plus some other complication, which could be perinatal morbidity or maternal preeclampsia. So it was the outcome was a baby that was small plus some other form of complication, indicating that this was fetal growth restriction, not simply a healthy small for gestational age baby. And these are the screening data that we achieved. So this is the 36-week assessment, and then relating the measurements at 36 weeks to the subsequent outcome. So a baby that's just on its own small was about 5 times more likely to experience the outcome that I just described. If the SFLT1 ratio was elevated, the baby was around about 4 times more likely to experience the complication I just described. But with the combination, there was a almost 18-fold increase in the risk of that complication. Now, the best way to articulate some of the other screening statistics is to show you something that's really just a very simple clinical thing. And that is, let's take each of these as being a screen positive test. How many false positives were there for every true positive? So if you do a scan at 36 weeks gestation age and you blind the result and you watch what happens, for every one small baby that experiences that complication, there'll be 12 babies that were small on scan where the outcome was completely normal. So you have to think in terms of how is your intervention going to cause more good to the one baby that's actually a true positive than it causes harm to the 12 babies which were false positive. SFLT1 PLGF on its own, even worse. For every one baby that had that complication, there were 17 that didn't. But when we look at the combination of the two, the baby that's small on scan with the abnormal biomarker ratio, for every one true positive, there were just 4 false positives. And for me, it's much more plausible that this population, where the baby's both small on scan with an abnormal placental biomarker test, that we can intervene at 36 weeks gestational age and actually improve the outcome in these cases. So our second goal was to perform a randomized controlled trial of screening and intervention, and that's what's in progress at the moment. So we have funding from the Wellcome Trust in the UK for a proof of concept randomized controlled trial. So at the moment, we're trying to run the POPs2 study, where we again see women throughout the pregnancy, as we did with POPs1, to create a biobank of biological samples. But then at 36 weeks gestational age, make this combined ultrasonic and biochemical assessment, identify the women who are high risk on the basis of the test that was developed from the original POP study, and then randomize these high-risk women to intervention, which is principally to reveal the result and recommend early term induction of labor or routine care. And one of the advantages of this study design is that we can both determine, does the intervention actually improve outcome when we compare those where we intervened with the high-risk patients where we didn't intervene, and we can also validate our tests by comparing the routine care high risk with the routine care low-risk patients. And this study is in progress at the moment, but obviously been somewhat affected by the COVID-19 pandemic. So we think this approach has some promise, but the sensitivity of ultrasound and SFIT1-PLGF is about 40%. So the outcome that I described, only 40% of the women experiencing that outcome actually screened positive for the test. And a probable explanation for this is that fetal growth restriction is the endpoint of multiple different pathways, and SFIT1-PLGF is specific for one type of fetal growth restriction, and that's the type which is associated with preeclampsia. Actually, this bears out. So this is another analysis from the Lancet paper in 2018. SFIT1-PLGF is an incredible predictor of fetal growth restriction with preeclampsia, with an area under the curve of 0.95. Now, area under the curve, 1.0 is perfect prediction, 0.5 is no prediction at all. So what we can see is a value here that's really quite close to perfect. It's very unusual for a baby to have fetal growth restriction with preeclampsia, even at term, and have a normal SFIT1-PLGF ratio. But for fetal growth restriction without preeclampsia, 0.5 is no information at all, 1 is perfect, well, we've got a value of 0.6. So actually, SFIT1-PLGF doesn't tell us nearly so much about fetal growth restriction that's not due to preeclampsia. And so the unmet need is to identify predictors of other types of fetal growth restriction. This is where we got on to the second paper, which is the paper published in Nature Medicine in March last year. And we're looking at a range of potential biomarkers using a range of technology-based platforms. And we've got active programs in all of these: proteins, nucleic acids, metabolites. But what we're going to do is describe the work that we generated on metabolites. So what metabolites are essentially small molecules which are defined as the products of metabolism. They're made from something else by an enzyme in the body. There's a whole range of different metabolites, things like amino acids, carbohydrates, lipids. We used a technology platform by an American company called Metabolon, and essentially Metabolomics has two key components. You first of all take your sample and separate the sample on the basis of broad chemical characteristics using chromatography, and then you analyze the sample using mass spectroscopy, which then gives us data on hundreds of known metabolites. And our approach here was to assess the associations with term fetal growth restriction using linear regression of values at 12, 20, and 28 weeks, perform internal validation using a 36-week gestational age sample with correction for multiple comparisons, and then to externally validate the test in as different a population as we were able to find. This is where the loss of animation, unfortunately, messes up a little bit here. But we have 4 predictive metabolites which we identified by this process. So you can see we initially identified them by the 12 to 28 week samples. And actually, so it's rather ad hoc animation. What we can see is that when we then went to validate them at 36 weeks gestational age, the difference was actually bigger, which is consistent with this being a true predictor of fetal growth restriction and not false discovery. And getting potential markers using these omic technologies, where you're testing hundreds of predictors, getting a false discovery, thinking that something's truly associated where it's not truly associated, is quite a common problem with these. But what we see is the signal gets bigger as we get closer to the delivery, which is consistent with a true signal. So to cut a long story short, here are those 4 metabolites, 2 of them positively associated, 2 of them negatively associated. So one of them is a thing called a plasmalogen. This is a carbohydrate derivative. This is a steroid, an intermediate prior to estrogen synthesis, and this is a thing called a polyamine. And there were 2 of the metabolites were positively associated with fetal growth restriction and 2 negatively. And so we created a ratio of the 2 positively divided by the 2 negatively that had an area under the curve of 0.78. And we always consider what's the possibility that this is a chance finding, and our p-value here was 10 to the minus 21. So it was essentially impossible that we'd come up with this through the play of chance. We then compared the ratio with SFIT1-PLGF. So when we look at all fetal growth restriction, and this is defined as a baby less than the 3rd percentile or less than the 10th percentile with ultrasonic evidence of FGR, the metabolite ratio was better than the SFIT1-PLGF. So what we have in the x-axis here is the area under the ROC curve. 0.5 is a test that tells us nothing about fetal growth restriction, and 1 is a test that's a perfect predictor of fetal growth restriction. So the further to the right the given value is, the better the prediction. So for all fetal growth restriction, metabolite ratio in black performed better than the SFIT1-PLGF. Birth weight less than a third performed better. Birth weight 4th to 10th, but with reduced growth velocity, again better. The only case where the SFIT1-PLGF ratio was better was fetal growth restriction with preeclampsia, where, as I said before, SFIT1-PLGF is an almost perfect predictor. Metabolite ratio doesn't perform so well. But crucially, fetal growth restriction without preeclampsia, the SFIT1-PLGF ratio doesn't tell us very much at all, but the metabolite ratio gives us much better information. This is another bit where the animation falls down a little. So we went to validate this in a completely separate population. And this is a population called Bourne and Bradford. They had bloods obtained between 24 and 28 weeks gestational age. So again, we have the AUC as the prediction. We looked at the association across different ranges of gestational age in the POP study. This is 20 weeks, 28 weeks, and 36 weeks. And then when we look at Bourne and Bradford, we actually see a similar association at 24 to 28 weeks in this separate population. So the ratio is similarly predictive in a completely different population. And why is this important? Well, Bourne and Bradford was a completely different population to our Cambridge population. So we studied exclusively first pregnancies. Bourne and Bradford, they were mostly Paris. In POPs in Cambridge, we have a population that's 93% white ethnicity. In Bourne and Bradford, it's about 50% Pakistani. So most of these women are of Pakistani, about half of these women are of Pakistani ethnicity. Deprivation is very uncommon in Cambridge, but much higher in Bourne and Bradford, and even the sample types are different. So we use serum, and Bourne and Bradford used fasting plasma. So seeing the same strength of association in a completely different population, even using completely different samples, is very reassuring for us that we're looking at something that's likely to be real and likely to be generalizable. We then wanted to see how could this actually work in practice? How would this ratio help us in terms of screening the population and identifying risk? And we make the measurements at 36 weeks gestational age. We could separate our POP study participants into 3 groups. So there's about 7% of women where both the ratio and the estimated fetal weight are in the extreme 20%. So it's the estimated fetal weight is less than the 20th. The ratio is higher. Actually, that should be greater than the 80th. And the risk of term fetal growth restriction is 1 in 3. Now that is an astronomically high relative risk. So that's 2 false positives for each true positive. Conversely, we've got the estimated fetal weight is above the 20th percentile and the ratio is not elevated, and the risk of term fetal growth restriction is 3 per 1,000. So we have, and that's about 60% of women. So 2/3 of our population can be separated into either having a very high risk of fetal growth restriction or a virtually 0 risk of fetal growth restriction. And there's a group in the middle where the risk of term fetal growth restriction is intermediate, who would require further testing. But this looks to us as if it has potential utility. And this is one of the areas that we're working on, is coming up with a quantitative version of the metabolite ratio, and then looking to see if we can turn this into a usable clinical test. So in conclusion, I don't think we can say that we know that universal ultrasound isn't useful. We just don't know one way or the other. Universal ultrasound could be useful, it might not. But a problem with universal ultrasound is that if we do it and all we do is spot small babies, you're going to end up with huge numbers of false positives where you intervene in the pregnancy in a case where intervention does no good and intervention has the potential to cause harm. You deliver babies early, you spend money, you make mothers anxious. There's all sorts of bad things from unnecessary intervention. As something that we might be able to do now, we believe that the combination of ultrasonic diagnosis of small babies plus an elevated SFIT1-PLGF ratio might be better, in that we would have many more true positives for each false positive. And we're currently engaged in a randomized controlled trial to address that question. But we also see that fetal growth restriction is the endpoint of multiple pathways, and it's unlikely that a single approach will have high sensitivity. And that's the realizing that is the thing that's leading us to look for other markers which can detect different phenotypes of fetal growth restriction, which could result in improved clinical prediction. And our initial results in that we think are quite promising, and we have other lines that we're also following up where we think there's a real prospect that we can begin to think about introducing supportive tests that we can do in parallel to ultrasound to try and improve our targeting of intervention to women who have the highest risks of complications. So I'd like to acknowledge some of the key people involved in the POP studies. Ulla is our statistician who's performed a lot of the analysis, particularly some of the complex analysis of omic data. Steve Charnock-Jones is my collaborator on the lab side and has been incredibly useful there. Francesca is one of our postdocs who's led some of this work, and Emma Cook looks after the biobank of 250,000 little bits of tissue and blood, and is a much wider range of people who helped collect the data and have analysed it. And I'd be happy to answer any questions.
Thank you, sir, for that excellent talk. Now I request the chairpersons to give the valuable comments.
Thank you, Professor, for that wonderful talk and amazing results. Actually, when you talked about the metabolites, they were really amazing the way you showed that they had a good predictive value. I just want to refer to the Swedish study that you showed, in which you showed that the perinatal mortality or the morbidity increases when the baby's weight falls to less than the 50th centile. If you looked at your chart, you would see that it sort of goes exponentially up once the baby's weight falls less than the 50th centile. So when we concentrate our efforts on only those fetuses with an estimated fetal weight less than the 10th centile, aren't we losing out on all those fetuses with an unmet need between the 10th and the 50th centile? And that's what was shown in the, I think the birth registry from UK, which is published by the FMF, where around 40% of your stillbirths are going to be actually AGA babies above the 10th centile.
Yeah, sure.
Yeah.
I mean, I think when we think about how we prevent stillbirth, I mean, what my approach is, do the thing that's easy first. You don't start off doing the difficult thing. You do the thing that's easy, and then once you've done the thing that's easy, you do the thing that's next most easy. The thing with growth restriction is it gives us a potential marker to assess risk, because we can assess the size of the baby ultrasonically, we can assess it biochemically. You're trying to identify that normally grown baby who's going to be stillborn. It's just actually really, really difficult. I mean, where do you even start? We don't have good ultrasonic markers. You would need to be collecting hundreds of thousands of samples in order to be able to identify your biomarkers. So it's not that I would say we're not interested in the appropriate for gestational age stillborn baby. It's just I find it much harder to see how we can actually do something that has an impact on clinical care. So it's a little bit like the going for term thing. You do the thing, take the low-hanging fruit first, and then once you've got the low-hanging fruit, then do the next, then climb slightly higher up the tree. Now, one of the things that with the POPs2 study, getting the research funding to do the randomized controlled trials then allows us to collect another 250,000 biological samples. And one of the ways that I see this is as we get the research funding to do the randomized controlled trials, it then allows us to gather more and more biological samples that we can then analyze. So the POPs3 would have to be a massive population study with maybe tens or even hundreds of thousands of women, where we can collect the blood from those women and then start to analyze the things that are predicting term stillbirths where the baby is appropriate for gestational age. So it's not that I would discount that, and I certainly recognize it's actually only a minority of term stillbirths where the baby's small. But it just seems to me that that's the group where we've got a potential handle in screening and intervention.
I guess it goes with your analogy of the fire at the basement.
Yeah.
The people but another thing that I noticed that you have not included Doppler in your screening protocol. But I was thinking if you use estimated fetal weight less than the 10th centile along with your S-flick ratio, and if you add Doppler also, wouldn't that change or improve your outcomes?
So if you go to that Lancet Child and Adolescent Health paper, we looked at Doppler. I presented a few slivers of the data. There's a mountain of data in that paper. And so we looked at another definition of abnormal ultrasound where we incorporated growth velocity and abnormal umbilical Doppler. And it wasn't much better than just a small baby on scan. So we've made that comparison with the sort of more sophisticated use of ultrasound. But it's just there's only a certain amount you can communicate in a 30-minute talk, so I didn't want to drown people in data. But if anybody's interested, that's the comparison with doctors there.
Yes, thank you so much. If anybody, I think there is a question in the chat box. I'll just
sort of same as what you asked.
Okay. The question is, if a biomarker is abnormal at 28 weeks, then how long is the pregnancy continued? Is Doppler also added?
Yeah, so again, we've done, so as part of the POP study, we published the 28-week data, and we looked at SLIT1 PLGF, and we also looked at, I don't know if you might have read, there's a Delphi consensus for defining fetal growth restriction, which is published from a team in Holland, Sandy Gurgen. And again, this is where the blinded approach in POPs was really helpful, because the danger is you do your test, you see the baby's small, you then deliver the baby prematurely, and then you do your research study and say an abnormal ultrasound predicts preterm birth. It's great, but it's just a self-fulfilling prophecy. All you're doing is you're detecting the effect of the intervention that you initiated because of the abnormal result. So in the POP study, we used that Delphi consensus definition for fetal growth restriction at 28 weeks, and we didn't do a thing. We just watched to see what happens. There were over 110 women who fulfilled that Delphi consensus. None of them had a stillbirth. Of that 110 plus women, only about 10 to 15 of them actually delivered preterm at all. So you have, the problem is if you do the scan and you think you've made the diagnosis, you then do another series of interventions that convince you that you were right. But if you actually just look at the natural history of the investigation, you realize that it's actually different. Now, the thing here is it depends on the population you're studying. So if you're looking at a woman who's had 2 previous stillbirths that are growth restricted, her prior risk of having a complication is much higher. And if that Delphi consensus is fulfilled, that then increases the risk further. But when you take a diagnostic test that you normally use in the context of high-risk patients and you apply it to a low-risk population, the danger is that low-risk population.
I think we lost you. I think your mic is, I think you've muted your mic.
Yeah, just that. So if you take a test which, if you take a test and then apply it to a low-risk population, you have a much lower prior risk. So for any given positive likelihood ratio, for any given increase in the risk that you get with a positive test, the actual, what we call the posterior risk for that individual is much lower. So it's absolutely classic thing is people develop a screening test in a high-risk population, it works brilliantly. They then go to the general population and then are astonished that it doesn't work so well. But the whole thing's around Bayesian statistics. You know, the test increases the risk to a degree, but the other determinant of the predictive ability of the test is the prior risk of the individual. And if you take that test and apply it to a low-risk person, you get lots more false positives.
Yes, you're talking about background probability. But the problem here is when you see a baby that's small at 28 weeks, it's very difficult for us to just leave that baby alone. That's another thing. Yeah, because and that's where we put them on serial follow-up and then try to do something to save the baby, even though it does not need saving sometimes. Yeah.
So the crucial thing to know is that depending on the risk profile of the mother, you might actually be harming the baby. So we have an exaggerated, I believe we have an exaggerated sense of how well we can predict stillbirth. But what we do know is if you deliver the baby prematurely, you're exposing it to the risk of neonatal death and lifelong harm. And that's why I'm very cautious about thinking about introducing screening in the preterm period, because your potential to cause harm is huge. So you might take a woman who appears to have an abnormal scan, you deliver the baby at 30 weeks, it dies as a neonatal death, where if you had done nothing, the baby would have been born at term. So it's not that you shouldn't screen, it's simply that you have to go into screening being aware that you can cause harm through your interventions.
Okay. I think we can, if there are any other comments from anyone, or we can go on to the next presentation. If that's okay.
There's one query. When placental pathology is similar for FGR and preeclampsia, why only some show biochemical abnormality?
Yeah, no, it's one of the really interesting questions is you might have an abnormal placenta and have a completely normal pregnancy outcome. You might have fetal growth restriction but no preeclampsia. You might have preeclampsia and no fetal growth restriction. And one of the things we're actively looking for are markers which go in different directions for preeclampsia and growth restriction. So most things, if they're associated with FGR, they're also associated with preeclampsia. So we published a paper, a Metabolomics, identified N1, N12 diacetylspermine as one of the first markers we have found, where if it was high, it increased the risk of preeclampsia, but it was associated with a decreased risk of fetal growth restriction. So that's actually a real key area of interest to us, is the same abnormal placentation can lead to different manifestations in different women. Some preeclampsia, some fetal growth restriction, and it's a really interesting question to understand why.
I think there's one more question here about first trimester screening for FGR. On your take on that, first trimester FGR screening with PLGF and PAPI and the uterine artery Doppler.
Yeah, so first trimester screening for preeclampsia, I think, is fantastically, of all the things you should be thinking about doing, that's absolutely up there. And the reason I say that is because we have an intervention. I mean, the thing with screening is you have to couple the screening test with an intervention. Otherwise, all your screening is going to do is going to introduce harm. You're going to make people anxious, you're going to waste money, and you're going to cause unnecessary intervention. But if you screen for early preeclampsia, then you have the intervention of 150 milligrams of aspirin at night. You know, the Aspirin Trial generated amazing data to indicate that you substantially reduce the risk of the most severe manifestations of preeclampsia for the baby. So in terms of screening for first trimester screening for FGR, I'd say no, because what's your intervention? First trimester screening for preeclampsia, early onset preeclampsia, which will sometimes be associated with fetal growth restriction, absolutely, because it's one of the most effective things we can do.
Yes, the false positive.
Thank you, sir, for sharing your experience.
Thank you, sir.
Okay, thanks so much. Thank you.
Just a clarification. So, even though the French experience has shown a lot of false positive and doing much harm than good, would you still recommend a universal ultrasound in the third trimester?
So I'm currently advocating that we do that in the UK, but for one thing and one thing only, and that's presentation near term. Again, it goes back to what's your intervention and how likely is it your intervention will do harm. I mean, we have midwives screening for breech presentation with palpation with a sensitivity of about 50%. So I do think we should be doing routine late pregnancy ultrasound for breech presentation using a handheld point of care ultrasound device, and with the option of then doing external cephalic version or cesarean section, or being able to plan the vaginal breech birth. So that's where I think there is a role for ultrasound right now, but I don't think there's a role for ultrasound right now in terms of predicting small fetal gestation age, because you'll cause more harm than good through unnecessary intervention.
Okay. Thank you, sir.
Thank you, sir. Thank you.
Thank you. Sorry about the technical problems. That was, but thanks for your time, and hope it was really very grateful for the invitation to speak to you guys. It's been great to participate in the meeting. So thanks very much.
Thank you, sir.
So once again, I thank sir and all the chairpersons for that wonderful discussion on fetal growth restriction, covering all the recent advances in the field. So now we move on to our third session on management of preeclampsia. For chairing the session, we have eminent professors, Professor Dr. Serena Gilvas, Professor Dr. Mini CH, and Professor Dr. Vinay Chandran. It's my privilege to invite Dr. Serena Gilvas. Madam is the professor and head of the Department of OBG at Jubilee Mission Medical College, Thrissur. Madam was the past president of Thrissur Obstetrics and Gynecological Society and was the scientific chairperson for AICOG 2006, which was held at Kochi. Welcome, Madam. Next, I would like to invite Professor Dr. Mini CH. Madam is the professor and head of the department at Government Medical College, Calicut, and is the present executive member and scientific chairperson of Calicut Obstetrics and Gynecological Society. Welcome, Madam. Now, next I invite Professor Dr. Vinay Chandran, sir. Sir is the professor and unit head of Department of OBG at Malabar Medical College, former professor and unit head at Government Medical College, Calicut, former head of the department at Government Medical College, Kannur and Manjeri. I was the past president and secretary of Cogs. Welcome, sir. Now I request Professor Dr. Vinay Chandran, sir, to introduce the speaker.
Hello, can you hear me? Because my video is muted.
Yes, sir. You can hear. Sir, we can't hear you, sir.
Yes.
Dr. Vinendran?
And video and audio is muted from the host side. Now it is okay. Now it's okay? Can you hear me?
Yes, sir. Yes, sir.
Yes, sir.
I take this great privilege to introduce the legend, Professor James J. Walker, to this webinar on high-risk pregnancy. I must say that none other than Professor James J. Walker can talk on the subject preeclampsia. Actually, he started his graduation from Glasgow and post-graduation from Glasgow, and then he moved to Leeds, where he blossomed. He's a Professor Emeritus of Obstetrics and Gynecology, University of Leeds. Now, he previously Professor of ONG, University of Leeds and NHS Trust until the end of September 2009. He was a Medical Director, Action on Preeclampsia since January 2009, Senior Vice President RCOG, leading on global affairs, Chairman of Center of Maternal Child Health Enquiries, April 2009 to June 2011. He had special interest in the etiology, pathology, and treatment of miscarriage from the Glasgow days even. And she has got special interest in the preterm labor and in the identification of the high-risk factors in the preeclampsia and the management of preeclampsia. He developed a protocol for use of labetalol to control BP and prevent death from cerebral hemorrhage, and the run them dry management for fluid replacement to reduce the death from pulmonary edema in preeclampsia. And to his credit, he has got more than 250 publications. Now, the floor is yours, sir.
Thank you very much. I'll just share my screen. And it's this one. No, you've got my diary. That's not what I want to do. Can you see my slides?
Yeah, we can. We can.
Okay, so I can't see the screen, unfortunately, so I don't know what I'm sharing. So thank you very much for inviting me to this meeting. It's been very good to be involved with it, and I've enjoyed the talk so far. I'm going to present a very clinical talk on the management of preeclampsia. Now, a lot of this work is based on what's already been said from coming out of Glasgow, but a paper which we published from Yorkshire, where we looked at over 1,000 women who came through the Yorkshire protocols, and I'll be describing what they were and how we managed them, and the basis of the UK preeclampsia guidelines, the NICE guidelines, and were based on this work. So I'll start. I want to go through the various points from pathology to assessment to management and delivery. As far as the pathology is concerned, and Gordon Smith's already touched on this, and I think it's important to emphasize, there's no doubt that there is a lot of evidence suggesting that placental pathology, particularly problems with implantation, can lead on to development of preeclampsia and associated with preeclampsia, and particularly associated with preeclampsia in the small baby. And this can be looked at by uterine artery ultrasound, looking at blood flow as early as 20 weeks, or even sooner than that, to try and show differentiation between mothers with a placental problem, which could lead on to preeclampsia, and those without. The important thing to remember is that overall, of all the women who have a small gestational age baby, only about 25 to 26% of them will develop preeclampsia. So although we can screen for women with potential or placental abnormalities and growth restriction, that only 25% overall of the severe group will actually then go on and develop preeclampsia itself. The majority of women who have small fetus babies are normotensive. So the association is not a complete one. Similarly, so therefore, if you're looking at the pathology from the baby, from the placenta, it's the added pathology which you see in the mother, which differentiates a baby which is small for dates itself and a mother with preeclampsia and small for dates. And this is where the biomarkers come in and the changes in the biomarkers come in. And the evidence would suggest that a lot of the biomarkers that we routinely look for preeclampsia are maternal biomarkers and not related necessarily to the placenta itself. The classic signs that we see are signs of inflammation, particularly relating to the blood vessels, causing endothelial dysfunction and therefore high blood pressure, but also platelet activation with falling platelet counts and rising uric acid, and also a capillary leak which occurs, which causes edema, as well as proteinuria within the kidney. And looking for these signs can tell you whether there's a systemic problem in the mother, which means she has a preeclampsia, which will tend to progress. If you then look at preeclampsia itself and how it presented, the majority of people with preeclampsia present at term. Overall, there's about 5% of the population will develop preeclampsia, most of them at term, and about 25% preterm. But if you look at less than 34 weeks, you're talking about less than 10% of the pregnancy population, of those with preeclampsia itself. And again, if you look at preeclampsia and small for dates, only 25% of women with preeclampsia will have a baby which is designated small for gestational age. So this association between hypertension and growth restriction is a varied one. Also, if you look at gestational hypertension alone, and that is the disease without the evidence of proteinuria or systemic disease, you can see that the majority of them are at term, and preterm gestational hypertension is quite rare. And again, you have about 20% chance of some growth restriction with gestational hypertension, even in the absence of preeclampsia. Although under some of the new guidelines, these patients would be included in the preeclamptic subgroups. So with that background of pathology, how do we assess the mother and baby? Now, the important thing to start off with is that the good antenatal care is based is the mainstay of obstetric practice. And where antenatal care is poor, maternal and fetal mortality and morbidity is poor because things are not picked up. Antenatal care is a screening process. It was first designed to screen for preeclampsia, but it can screen for other things as well. So the importance of antenatal care by quality medical attendance or midwifery attendance is actually very important because it picks up early signs which you then can further investigate and further intervene with. So antenatal clinics are risk assessment clinics. Blood pressure should be measured. A urine test is for protein. Asking for symptoms such as headache and other symptoms like abdominal pain are all methods of looking for early onset signs of preeclampsia, which could advance to more severe disease. So again, it's a screening for preeclampsia. High blood pressure should be defined as over 140/90. Now the reasons for that is that below 140/90, it's rare for a mother to have any significant condition or morbidity. You still can get growth restriction, and if you suspect a baby is small, then you should investigate accordingly. But in general, 140/90 is a cutoff point where once the women have a blood pressure of that or above, they are out with the normal range and should be monitored accordingly. That does not mean they need treatment. It does not mean they need antihypertensive therapy or delivery. It's important you actually take an average of 3 blood pressure readings to improve the accuracy of blood pressure measurements. You should not take the lowest level of 3, but the average of 3 to try and assess what the blood pressure actually is. Proteinuria is an important marker because it tells you there's something systemic going on. This is not renal damage, it is leakage of protein with fluid into the tubules and then leaking into the urine, and can be picked up by simple stick testing. The absence of proteinuria of someone with hypertension reduces the chances of that woman developing preeclampsia, although her blood pressure may be of severity enough to require treatment. So proteinuria is a gateway investigation. If it's present and along with hypertension, the woman should be admitted to hospital with a diagnosis of preeclampsia. there's then little evidence that the level or change of level of proteinuria is related to outcome. So once you've confirmed proteinuria, and you may want to confirm it with some a better test than stick testing, there is no reason to repeat that proteinuria measurement, as it has little value to how the outcome or how you manage that woman. Once confirmed, and therefore you don't need to follow up by repeated proteinuria testing. As far as symptoms at presentation of someone with hypertension in pregnancy and relating to either PET or those who present with eclampsia or will develop eclampsia, the only sign which differentiates is headache, which is more common in women with eclampsia than women who have preeclampsia, with eclampsia than women with preeclampsia alone. Therefore, people with high blood pressure with persistent headache should be treated more seriously as a risk of eclampsia than women who do not have headache. Headache is the most common sign of women with preeclampsia, followed by epigastric pain. The things like clonus and increased reflexes are of no value in differentiating between severe preeclampsia and eclampsia itself, and has little value overall in the management of these patients. Now, as far as the pathology that we see, the progression which then we can monitor is partly looking for blood pressure relating to the vascular reactivity. We look at platelet counts and problems of kidney function, and we look at in the liver and for liver dysfunction related to the inflammatory processes there. So when you're looking for the diagnosis of preeclampsia, it's a rise of blood pressure, the presence of proteinuria, falling platelets, rising ALT, rising uric acid, and other signs which develop, such as headache, abdominal pain, and intrauterine growth restriction. Now, what's important is you don't need all these measurements, because you may have people with completely normal liver function, although they have falling platelets and rising uric acid. So you can't be reassured by the absence of some of these parameters, but you should be concerned with the presence of them. Now, once you've diagnosed it and you've monitored it and you've got the woman in hospital, the next point is how you manage that woman ongoingly. Now, the important thing is that delivery, it leads to the cure of this condition, although it may take about 24, 48 hours for the woman to get better after delivery. Therefore, the plan of management of anyone with preeclampsia is to optimize the woman's condition and optimize the time of delivery to the benefit of the mother and baby. Delivery too soon when the mother's not stable is dangerous to the mother and can cause prematurity in the baby. Waiting too long can cause intrauterine death. So it's that balance between the benefit to the mother and baby of prolongation of pregnancy. So the benefit to the mother is you must always stabilize her prior to delivery. And what that means is you have her blood pressure under control. If she has convulsed, she should be then given magnesium sulfate. As far as by stabilizing her, you actually reduce her postnatal risk of increasing hypertensive problems. Remember, the majority of women get worse after delivery. So the more stable they are before delivery, the less severe they become after delivery. As far as the baby is concerned, the prolongation of pregnancy is the only benefit as long as the baby is healthy and the mother is stable. And you use that time for benefit to the baby, maybe giving steroids prior to delivery, transfer to another unit if that's of benefit, or just organizing the relevant support staff to be ready for delivery itself. Prolongation of the baby prolongation of pregnancy for the baby is also a benefit if it's well, because it allows it to increase its growth and maturity. Now, when looking at maternal mortality, then by far the most common cause of mortality is cerebral vascular accident due to high blood pressure. And the next problem relates to primary edema relating to fluid management. The other causes of things like liver rupture and liver dysfunction are present, but of far less seriousness. And renal failure is rare, partly because when renal failure occurs, it is generally of an ATN type problem, which recovers with the appropriate support. So managing women to try and stop renal failure and by giving them fluid actually aggravates the problems of pulmonary edema, a far greater cause of death than reduces the probability of renal failure. So to lower the risk of cerebrovascular accident, we then think about how to lower blood pressure and when to lower blood pressure. The recommendation in the UK now is that if you have a blood pressure of 150/100, that you recommend to treat that woman to reduce her blood pressure down below 150/100. If she has a blood pressure over 160/110, that you must treat her because her risk of stroke is greatly elevated because of her, particularly her increased systolic risk, the systolic blood pressure. If we treat the woman by lowering blood pressure and keeping below the 150/100. Now we use this in the UK irrespective of the underlying cause of the hypertension, whether we think it's chronic hypertension, gestational hypertension, or preeclampsia. If you're treating hypertension, you treat it the same way. In the UK, labetalol is the first-line therapy, partly because it's the only licensed drug in the UK for use in pregnancy. And studies have been showed as at least as good as any other. And a recent study coming from Nagpur in India showed that nifedipine and labetalol were very similar in action, although labetalol had less side effects, and both were superior to methyldopa in controlling blood pressure in the immediate term. The dose of labetalol is usually 200 milligrams orally, and this is repeated hourly until blood pressure is controlled. And that controls about 80% of all women without use of any other antihypertensive therapy. You can use intravenous therapy, which can be used with women who are unresponsive to oral therapy. But generally, if you need intravenous therapy, you're probably going to end up delivering that woman in the relatively near future. Nifedipine is 10 milligrams of slow release as a single dose, then repeated either every 20 minutes or up to every hour till a maximum of 40 milligrams. And again, about 80% of women will be treated, will manage control on that alone. In cases where failure of labetalol and nifedipine occur, then the addition of the other drug increases the control by another 9 to 12%. So if labetalol then add nifedipine, or nifedipine add labetalol, will generally, and this is oral therapy, generally control blood pressure in the vast majority of cases over 90% of them. The aim is to stabilize the blood pressure prior to delivery. Now, if this woman has convulsed, there's good evidence that magnesium sulfate is the drug of choice because it's superior to diazepam and it's superior to phenytoin. But the important thing from this slide is to look at the yellow bars to show that even with treatment, some people will reconvulse. So that in the magnesium diazepam randomized trial, 30% of the women convulsed a second time after starting the therapy, although in the other trial, only 10% reconvulsed. So the risk of reconvulsion is present, but in general, if they do have another convulsion, they will not convulse again or have a reduced chances of convulsing again. Now, if they have an eclamptic convulsion, you give intravenous. Magnesium sulfate is the best choice, and that you can consider giving intravenous magnesium sulfate to women with severe disease, severe preeclampsia who have not convulsed, who are in a critical care setting if birth is planned within the next 24 hours. But the evidence of reduction of convulsion is that if you lower their blood pressure, the chances of the convulsion occurring in someone who has not convulsed before is greatly reduced. And it may be that you do not need to give magnesium sulfate prophylaxis, but there's no harm in doing it as long as it is adequately controlled. The dosage used in most places was the dosage used in the collaborative eclampsia trial, which is a loading dose of 4 grams over 5 minutes, followed by 1 gram per hour maintenance dosage. Recurrent seizures should be treated with a further dose of 2 to 4 milligrams given over 5 minutes. The importance is you do not need to give diazepam. You can just give the intravenous dose of magnesium to start off. You don't need to give any other treatments alongside it. Now, as far as the baby is concerned, you maybe stabilize the mother, but what's the risk for the baby? We've talked about IUGR, which occurs in about 25% of women who present with severe disease. Abruption was something, when I was a medical student, was thought as a very common problem in preeclampsia, but now it is not. It used to be 2/3 of all abruptions occurred in hypertensive women. Now only 1/3 of abruptions occur in hypertensive women. And that's probably due to increasing use of antihypertensive therapy, which reduces the risk of abruption. But prematurity is actually the biggest risk of babies and mothers with preeclampsia. And this rush to delivery, when not needed, actually adds to the morbidity the baby has. Very similar to what Gordon Smith was talking about with IUGR. So when to monitor the baby, you carry out karyotography at the time of diagnosis, and at least weekly, as long as the pregnancy continues, or if the woman reports a change in her fetal movements, there's vaginal bleeding, abdominal pain, or a deterioration in maternal condition. What the CTG gives you is an immediate assessment of how well the baby is. And as described by Arulkumaran earlier in the talks, so that you can get reassuring signs that the baby is well. Now, something to note is if a woman has a convulsion, you will often see fetal distress signs such as decelerations, but these will tend to settle once the woman has come out of the convulsion and starts to breathe again, because it's related to the maternal hypoxia. Ultrasound should be done at the time of diagnosis to estimate fetal, rather than growth, fetal size. Amniotic fluid assessment of the deepest pool, umbilical artery Doppler valensometry, and other fetal vessels if you wish to do that. There's no real value of repeating the size measurements for the baby before 2 weeks, although Doppler and amniotic fluid assessment can be done more often. You can repeat if there's a change in clinical condition, if there's a further question to answer. But in general, ultrasound gives you an immediate assessment of the baby's growth and things like umbilical Doppler and amniotic fluid volumes, which gives you information how well that the baby is at that given time. When to arrange the birth is the most important thing of all. You arrange, in general, birth should be carried out if blood pressure control worsens, if bloods are worsening, particularly falling platelets, if there's signs of developing HELLP syndrome, and if the woman has eclampsia. Usually, pregnancy can be extended for around 10 days, 10 to 15 days from the initial diagnosis in most women with severe preeclampsia. Now, whether you do extend it, it depends on the gestational age the mother is at, because the benefit, remember, is for the baby, not for the mother. So at term, for instance, there's little evidence of benefit for the baby, but prolongation could harm the mother. So looking at the progression from the pathology, that obviously massive edema, and as you see in this woman's case, who's being ventilated, is a severe endpoint of the edema, the capillary leak, the problems of high blood pressure and cerebral irritation. But as far as she's concerned, her long-term survival depends on whether she's a stroke or not. So if you have a situation where you've got evidence of a stroke, then she will have long-term damage. Cerebral edema is not something which produces long-term damage as long as she's stable and oxygenized and comes through it appropriately. Once the woman is delivered, remember, people often get worse. And so therefore, ongoing monitoring is important. But after delivery, the two main problems for the mother is pulmonary edema, and for the baby is prematurity. So if you manage the woman, the planning the time of delivery is the most important factor. And I want to divide it into less than 34 weeks, 34 to 37 weeks, and after 37 weeks. And then potentially caring a bit about caring after delivery. Up until 34 weeks, this is a woman who's severely ill, tends to be worse and more acute problems than someone presenting at term. It's important to lower our blood pressure. It's important to plan for fetal monitoring. So senior obstetric staff should be involved. And the clear documentation of what the plan for this pregnancy is should be made. and the woman should be monitored daily and reviewed. Prolongation of the pregnancy in the absence of convulsions may be possible, as I say, for up to 10 to 15 days. But even a few hours for preparation or transfer of this baby to another unit for neonatal care, or for getting everyone ready to manage the baby, and also the presence of an ICU may be important for the mother. A few days allows the use of steroids, and for more than a week increases the fetal survival. However, if there's signs of fetal compromise, then delivery is necessary, and it's better to deliver a small, healthy baby than a bigger but compromised one. As far as delivery, if you look at early delivery in this group of babies, you increase the live birth rate, but you increase the section rates, you reduce birth asphyxia, but you increase the long-term neonatal death rate and increase long-term sequelae. Whereas delayed delivery increases the intrauterine death rate, but you decrease the section rates, increase the birth asphyxia, but reduce the overall neonatal death rate and reduction of prolonged long-term sequelae. So on balance, under 34 weeks, prolongation of the pregnancy appears to be beneficial for the baby, if you can leave the baby in utero for as long as possible. So consider birth, but give steroids, and but particularly deliver if the woman's blood pressure is not well controlled or indications seem to demonstrate that the mother or baby is worsening. Between 34 and 37 weeks, there's less information available. But in general, again, if hypertension is severe or the blood pressure is not controlled, and then a course of steroids have been given, then delivery may well be beneficial. But you would consider birth if the hypertension is mild to moderate, depending on maternal and fetal conditions and risk factors, and the availability of neonatal intensive care unit. In general, though, prolongation of pregnancy still helps the baby, but of a less increase of benefit as there is less than 34 weeks. So again, if you look at the benefits of early delivery, you get the benefits, the same benefits as before, but the neonatal benefits actually don't really have the same strength of benefit for the baby. So in general, if there's concern about decreasing or deteriorating maternal and fetal condition, delivery less than 37 weeks is probably of benefit. After 37 weeks, it's quite simple. In general, that you recommend delivery within 24 or 48 hours of admission for all women with preeclampsia after they're stabilized, as long as the availability of postnatal care for high dependency units or intensive care units or baby units, if required. In general, though, that once a woman is stable, delivery at this time is a benefit because it saves the mother from complications, and it does not harm the baby. In fact, if you look at the outcome, interestingly enough, early delivery by induction of labor decreases the overall cesarean section rates in this group, compared with delayed delivery, where you have increased emergency delivery, which is often by cesarean section. So overall, the benefits would appear to be beneficial for early delivery after 37 weeks. So once the woman's, the point of delivery is on the best way and the best day, then you need to manage her after delivery. There's little evidence of how to help you choose what the best way is. The mode of birth should be according to the clinical circumstances and the woman's preference. Before 34 weeks, in general, if it's a viable pregnancy, cesarean section is your best option. Between 34 and 37 weeks, consider whether the woman is parous and therefore it will be an easy delivery, or whether use of prostaglandins allows you to have a successful vaginal delivery. After 37 weeks, induction is preferable if that's going to be straightforward and relatively easy. Now, the important thing is that the woman is not cured immediately by delivery. The majority of women get worse after delivery, so it's important to manage her accordingly. In this situation, antihypertensive therapy continues and then reduces it slowly as blood pressure settles. Now, sometimes you get a reduction of blood pressure within the first 12 hours of delivery, but it will rise again at 24 hours. So you've got to be careful of that. If a woman is on anticonvulsant therapy, you can stop 24 hours after delivery as long as the mother is stable. but the most important thing is fluid management. Remember that overall, it's the second most common cause of maternal death in preeclampsia. So you should not use plasma expansion unless you're using a vasodilator drug such as hydralazine. Intravenous fluid should be limited to 80 mLs an hour, and unless there's other ongoing fluid losses, for example, hemorrhage. And in that situation, invasive monitoring might be required to balance the need of fluid against the risks. Now, if you put all these things together and what's happened in the UK, you can see that the thick red line is the total causes of mortality from preeclampsia since 1958. A steady reduction over the years with a continued reduction right up until the last decade. And the dots you can see are where certain guidelines came in. The green dots here are the hypertensive guidelines. The red are where we brought in the fluid management guidelines. And the pulmonary edema you can see in yellow here disappearing. This is the cause of death from cerebral accident. So there's benefit from these interventions that have been brought in over the last 30 years or so. And now in the UK, with early diagnosis, lowering blood pressure, monitoring the mother carefully, delivering the baby at the right time, with fluid management, we now have about 1 woman in 1 million pregnancies who now dies from preeclampsia in the UK, which means in the UK, since we only deliver 770,000 deliveries a year, we have years where there's no death from preeclampsia at all, compared with figures of 30 or 40 going back into the 1960s. So I'll stop at this point and just read a description of how the journey we've gone through in managing to preeclampsia, to keeping the mother and baby safe. Now, further studies, such as what Gordon Smith's been talking about, of use of biomarkers, are going to help us, I think, in further differentiating and diagnosing this condition. But simple, straightforward clinical approach it can be extremely beneficial. Thank you.
Thank you, sir, for the excellent coverage on the preeclampsia, from the way to diagnose it, manage it. And there are a few queries coming up. One question is proteinuria mandatory to diagnose preeclampsia?
No, when I grew up, it was the you had to have hypertension and proteinuria. But in fact, there's evidence now that there are women who don't have proteinuria who have other signs such as raised uric acid or raised ALTs or growth restriction and other things which could be labeled as preeclampsia, and they then are brought under the same umbrella and management. But proteinuria is the most common sort of sign in this condition, but it's not mandatory.
But sir, in superimposed preeclampsia in chronic hypertension, they say that proteinuria is mandatory. Why is this so?
Well, that's a slightly different thing, is that you've got someone with a background hypertensive problem, and you want to see whether there's a change. So therefore, the presence of proteinuria is a sign of systemic involvement. Now, the thing is, you could measure other things such as liver function or kidney function, and that may well give you the same information. So remember, proteinuria is just a clinical sign of this condition. It's not a pathology as such, because the proteinuria disappears quite quickly after delivery in most cases. So therefore, it's a very useful sign, but the presence of proteinuria, it confirms diagnosis. The absence doesn't mean it's not there.
Will you give routinely magnesium sulfate prophylaxis in severe preeclampsia?
Do I give routinely? I don't give magnesium sulfate routinely in severe preeclampsia, although many of my junior staff do, and if they do, I don't stop it. But I don't think it's necessary if there's no other signs of obvious systemic effects. In the absence of headache, for instance, even with quite high blood pressure, I think the chances of eclampsia is quite low. And in fact, in most studies, that in my study out of Glasgow, our risk was 1 in 500 women with severe preeclampsia convulsed if you lowered their blood pressure. So the risk is really low. So I don't routinely. It is part of the guidelines in the UK to consider it, and a lot of people do. And I would never criticize someone for doing it, but I don't personally.
How long you continue with against sulfate prophylaxis?
Well, that's the problem. And that in general, if you're going to give meson sulfate prophylaxis, you want to start it if you're going to deliver the mother within the next 24 hours. So you don't want her on long term before that. After delivery, you can stop it at 24 hours if the mother is stable and appears to be getting better. If you've still got concerns about the mother, if she's not fully conscious or her blood pressure is poorly controlled, then you can continue with it. And there's no real time limit for that. You can continue for 24, 48, 72 hours if you think it's necessary. But if the woman is stable as well, it can be stopped at 24 hours.
Can you stop it earlier? Because if you are finding...
Yes, I mean, again, in my situation, that if at 12 hours is someone who's come through labor and is well, and at 12 hours is fine and is passing urine and everything else is satisfactory, you can stop it then too. So it can be stopped. 24 hours is a reasonable time. Clinical judgment can allow you to stop it before that or after that, depending on how the woman is.
So you can take diuresis as one criteria so that you can stop it earlier.
Yes.
Thank you, sir.
Professor Walker, I wanted to really congratulate you on the brilliant lecture. It was so practical. And what was very consoling was that we probably follow about the same mode of management as you do. The only thing about the antihypertensives, we use a lot of nifedipine. And when you're talking about the time of starting the antihypertensives, you were telling us that to say that it is hypertensive, you say persistent 140/90, right? We too agree with that. And you were saying 3 readings. So one question to you was, what is the interval between these readings which you would like, the 3 readings which you said?
The readings should be done consecutively, every 5 minutes. So you've got 3 readings over 5 minutes. Fine. Blood pressure varies by 8 millimeters of mercury on a minute-to-minute basis in preeclampsia. So if you will see a variation, but the point is that you, by taking 3 readings and you average them, taking any more readings does not change the average to any extent. So 3 readings give you an accurate assessment of what the blood pressure is. Okay. You can look at the range if you want, but the average is actually quite a reasonable measurement to take.
Okay, but then you said that you would start your antihypertensives at 150/100. I thought now that is, we were also fighting for that once upon a time, that we would wait for 150/100 to start the antihypertensives. But now I thought it has come down and they said if you've got a persistent 140/90, you could start antihypertensives.
There are various studies like the CHIP study, which has come out looking at varying levels of blood pressure. What I'm quoting to you is what the NICE guidelines said, which is largely out of the work I've done in the past. The work I did in Glasgow suggested that starting at 140/90 was not beneficial as long as you kept an eye on them, because you could start the treatment at 150 over 100, and that's giving you plenty of leeway before any damage is caused. Now, we developed the process in Glasgow based on blood pressure measurement and weekly day unit assessments. So therefore, the woman to be kept within a day unit monitoring system. So if you're monitoring someone, generally, there'll be no problem for the mother or baby between 150/100 over to between 140/90. But there is evidence now that you can start treatment at that point, and it's not of any harm. But if you reduce blood pressure probably below something like 130/80, you may end up with increased growth restriction. So that's the problem of lowering the blood pressure too far. So I still would say 150, 100 is probably in this acute situation is when you start therapy. But in other scenarios, certainly in patients with renal disease, for instance, I would treat them to keep the blood pressure below 140/90. So there are situations I would use a different blood pressure measurement depending on the pathology of the Miller-Han's.
Then, sir, I've got another one question to you. This is a very practical question I'm asking you. Now, you said very rightly that when the patient requires parenteral labetalol, that means that pregnancy has got to be terminated. I think that's a very important point that you said. But what I want to know is now how we normally give it is we give in the Parkland regimen, we give 20, then 40, then 80. At a time, what do you say? Do we give 220, 300, or is it per day 300? That's what I want to know.
Well, the Parkland protocol was interesting. It was partly stolen from me, and they altered it slightly. But in general, that you need to give enough labetalol to lower the blood pressure. So that and what we tended to use, we use an IV infusion because it allows you to change what the woman gets over a period of time. In principle, a bolus of 50, which is what our starting dose would be, it reduces most people's blood pressure quite satisfactorily, and then you can repeat that. But we would actually give them 50 and start them on an infusion at that point, and then double the infusion rate until blood pressure control is achieved. Now, the reason I say you need to deliver them women is from our experience, we could never wean anyone off intravenous labetalol because they were thought to be bad enough to require it. So therefore, they were bad enough to require delivery as well. But the problem of all regimes is that the important thing about any regime is you give enough drug to be of benefit and you don't give too much. So how you give it doesn't actually matter too much as long as you're looking at overall the amounts that women get. In general, per day, then a woman should not really get more than 3 grams of labetalol because you start having major problems, particularly to the baby if the baby is still in utero. They start getting problems of bradycardias to a degree. But in general, once you're up to that level, you will not get any increased effect of increasing labetalol any further than that. And in most people, you don't need to go anywhere near that dose.
Okay. So I also like the way you said the importance of stabilizing BP. Second is about stabilizing the patient before induction, about the fluid management. I think it was a brilliant lecture. Thank you so much for all what you've said.
Thank you.
Mini Madam, we would like to have your comments on the topic.
Sir, I think this is how we also do our own managing. We do get a lot of cases with the preeclampsia and eclampsia. So I think I'm very thankful to you. Actually, you were also highlighting all these things. So really, we can be very happy and we can proceed in our own way. I think definitely. I think that there is not much time, Dr. Smita, isn't it, for a very elaborate discussion? I think so. We will have to stop at this. Thank you, sir, for all the good advices.
Okay.
Thank you. Thank you. Thank you, sir. Thank you, Professor Walker, for that wonderful talk. And I would like to thank all the chairpersons, Vinendran sir, Sarina ma'am, and Mini ma'am for chairing the session. We'll be moving on to our next session. The next session is on preeclampsia, long-term complications in the mother and child by Professor Eyal. To chair the session, I invite our eminent teachers, Dr. B. Prasanna Kumari, Dr. Radhamani, and Dr. Nishi Roshni. Dr. B. Prasanna Kumari Madam is a senior consultant at Lifeline Hospital, Adu, and professor and HOD at SUT Hospital, Trivandrum. She has also been the former president of KFOG. I welcome you, Madam. Next, we have Dr. Radhamani, professor and HOD at Department of ONG at Amrita Institute of Medical Sciences, Cochin. Madam is executive member and scientific chairperson of Cochin ONG Society. A warm welcome to you, ma'am. Dr. Nishi Roshni is additional professor of ONG at Government Medical College, Thrissur, and also president of Thrissur ONG Society. Welcome you. I welcome you also. I now request Dr. Nishi Roshni to kindly introduce our speaker. Over to you, ma'am.
Am I audible?
Am
Yes,
I
ma'am, you're
audible?
audible. Yes, ma'am, you're audible.
Good evening. We know that preeclampsia increases the maternal and fetal mortality and morbidity in the current pregnancy. Doesn't stop there, it occurs in the next pregnancy, and it has also got a long-term implication on mother. Not only it is a peculiar medical disorder that is specific to pregnancy, which attribute to fetal origin of adult disease. So to enlighten us on the long-term complications of preeclampsia on mother and offspring, we have an eminent speaker, Professor Eyal Sheena. He is a professor and chairman, Department of Obstetrics and Gynecology, Ben Gurion University of Negev, Israel. A postgraduate teacher was guide at 318 MD thesis, and he's a guide for 8 PhD students, and cited in Williams Obstetrics, ONG Survey, and ACOG. 478 publications, 50 review articles, and 12 editorials in international journals. He has edited 10 books and 45 chapters in textbooks, and 277 scientific presentations in international conference. A warm welcome, sir, to enlighten us on the topic. Over to you, sir.
Thank you very much. I will share my screen now. I would like to thank you for the invitation. And unfortunately, it's a webinar and not a frontal presentation, but I'm sure we'll have other opportunities. So I will speak about preeclampsia and maternal and offspring complications. Just a minute. I want to put it in a presentation mode. Okay. Can you see it? Can you see my slides?
No.
Not yet, sir.
No?
No, sir.
Oh.
Here.
Share screen.
Yes.
Yes, come.
Now?
Yes, sir.
Yes.
Visible.
Perfect. So let's go. This is a very famous graph of Satar. Satar showed that this is the risk for patients without preeclampsia for long-term cardiovascular disease, and this is the risk of patients with preeclampsia. Pregnancy is a stress test, and show that during pregnancy, those patients who had 1 or even 2 episodes of preeclampsia were those who were at higher risk for long-term cardiovascular disease because they probably had a lower threshold for cardiovascular disease, like endothelial disease or stuff like that. Which means that during pregnancy, we see the tip of the iceberg. We have an opportunity to detect patients who will be at risk for cardiovascular disease. However, other investigations and other theories, such as cytokines and S-split, which are secreted during the preeclampsia and which they can ruin the endothelium. Nevertheless, we know that preeclampsia is a disease of the placenta. It all stems from the placenta. We have abnormal transformation of the spiral arteries. We know that we have a problem with both the fetal and the maternal side. We have defective trophoblast invasion and we have problematic placentation. So we also know that preeclampsia is a disease that, which involves risk for the mother and child. So in this lecture, I want to concentrate about two things: long-term risk for the mother and then long-term risk for the child, because the short-term risks were already covered. I will present studies that we perform in my medical center. And can we do it? We have a tertiary medical center, and every delivery, after every delivery, the doctor in charge is summarizing all charts of the patient with ICD codes. And then it moves to secretaries that do it very carefully. So we have data, long-term data, which enable us to put every patient as a statistics as well. And during this time, we had almost 250,000 deliveries, because now we have 17,000 deliveries in my medical center. And as I said, this is the territory, the only medical center in the southern part of Israel. So if the patient is sick or the baby is sick after delivery, there are no other hospitals, only our hospital. So this is the Soroka University Medical Center, and we were able to define exposures and outcome. And the exposure here is preeclampsia, and the outcome is long-term risk for the mother now, and then we will discuss the child. We combined two different databases, the combined perinatal database and the hospitalization database. It was a very tough thing, especially to do it for the babies because they have other ID. And then after the end work, it was a very problematic work where the combined NETCH perinatal hospital database. And regarding the mother, I would like to speak about cardiovascular and renal disease, but also ophthalmic disease. So let's start. The first study we did was published in the Black Journal, and we were wondering whether patients with preeclampsia are at risk for long-term hospitalization. So it was a very simple study. We took patients with preeclampsia and we took comparison group of patients without preeclampsia, and we found out that patients with preeclampsia had 1.3 times risk to be hospitalized, and the hospitalization were basically in the internal medicine and neurological department and in the ICU. In a follow-up study, which was a very careful study, which was published in the Heart Journal, we evaluated the long-term maternal atherosclerotic morbidity in patients with preeclampsia. And here, all patients who delivered at our medical center between 1988 to 2012 were included. The exposure was defined as at least one episode of preeclampsia, and the outcome was hospitalization for any cardiovascular or renal morbidity. We excluded from the study multiple pregnancies. We obviously excluded patients with known cardiovascular or renal disease because those were not the issue. And we did advanced methods in order to control for the time of exposure. And that's why we did the Kaplan-Meier curves, which are actually survival curves, and the Cogs proportional hazard models, which are actually multivariate models that control for the length of exposure. In this data set, we had almost 100,000 patients. And take a look at this. 8% of our patients had at least one episode of preeclampsia during their pregnancies. When we compared cardiovascular morbidity, we can see that the risk was 2 times higher among patients with preeclampsia. It was almost 5% if the patient had preeclampsia, as compared to 2.7% in patients without preeclampsia, and the mean follow-up period was only 10 years. Regarding renal morbidity, it was very rare, but 2 times higher among patients with preeclampsia. And you can see here the survival curves. This stands for the years that passed from the preeclamptic attack, and this is the risk. And as you can see here, this is the risk for cardiovascular hospitalization, and this graph stands for renal hospitalization. And you can see here that patients with preeclampsia had higher, stronger, and faster risk for cardiovascular disease. They were more likely to develop cardiovascular morbidity even 5, 10, 16, and 20 years following the preeclampsia. The two graphs doesn't cross each other, which means that they were statistically significant. As you can see here, the p-values. Same was done for the renal morbidity, and again, you see stronger, higher, and faster effect of disease in patients with preeclampsia. We all know that preeclampsia is a variable disease. We have no preeclampsia, we have mild disease, and we have severe disease, and we have eclamptic seizures. And take a look at this. The risk for cardiovascular hospitalization was significantly higher if the patient had eclamptic seizure, 5.7%, as compared to 2.7% in patients without preeclampsia, meaning that we can actually see a dose-response relationship. If the disease was more severe, the patient had higher risk for cardiovascular disease. And the same for renal disease. The risk jumped from 0.1 if she didn't have preeclampsia to 10 times higher, to 1.1 risk if she had eclampsia. Obviously, we needed to control for confounders because many patients with preeclampsia have gestational diabetes, which is another strong risk factor for cardiovascular disease. And take a look at this. After controlling for many confounders, such as diabetes, maternal age, obesity, smoking, Even while we control for all those important confounders, the risk was 1.7 times higher, meaning a patient with preeclampsia is a significant and independent risk for long-term cardiovascular disease. Same was done for renal disease. The risk was 3.7 times higher, and it was independent of maternal age and diabetes. Now, this is a very cool slide because in the Heart Journal, you have to emphasize what is new in your study. And the things that are new in our study was first, the dose-response association between the severity of the disease and the risk for cardiovascular disease. And second, that the risk is not only for cardiovascular, but also for renal vascular disease. What about ophthalmic disease? Here, the risk of the disease is lower, but again, significant. And this study was published in the American Journal of Perinatology in 2016. And as you can see here, ophthalmic morbidity was significantly higher, 2 times higher if the patient had preeclampsia. And again, there is a dose-response association. The risk jumped from 0.2 to 2.2% if the patient had actually a clamptic seizure, 10 times higher. And again, we control for confounders, and you can see here that the graph, the Kaplan-Meier survival curve, is independent association in the Cogs and higher association in the Kaplan-Meier. And we all know that there are now many studies regarding this topic, and I'll show you here results of meta-analysis that summarized many studies and showed that the risk for coronary heart disease is statistically significant in preeclampsia. Likewise, the risk for death from preeclampsia is significant. And lastly, the risk for stroke is statistically significant following preeclampsia. The American Heart Association published guidelines regarding who is at risk for cardiovascular disease. And in their guidelines, I'll increase it in size, they wrote that pregnancy complications are a risk factor, are actually risk factors for cardiovascular disease. And what pregnancy complications? Exactly this one: preeclampsia, hypertensive disorders, and gestational diabetes. So, just before the corona, we had the FIGO committee. This is me here, the bald guy, and we gathered from all over the world, and we published the FIGO guidelines regarding what should we do for patients with preeclampsia. What is the long-term follow-up who is needed? And we summarized, it was published in the International Journal of Obstetrics and Gynecology in just the previous year. And we recommended that the following measurements should be implanted 6 to 12 weeks postpartum and periodically thereafter following a pregnancy complicated by hypertensive disorders. And take a look at those guidelines. They are very simple to do, very easy to do, no complications, no complicated guidelines. What are the guidelines? Take history and physical examination, take blood pressure measurement, and then if the patient is obese or she has other risk factor for diabetes, then do either oral GC glucose tolerance test or fasting glucose or hemoglobin A1C. The most important thing is that the patient should be familiar with the fact that preeclampsia is a sign they are at risk for long-term cardiovascular disease. They should control their hypertension. They should change their life habits. They should lose weight because it's in their hands. They are at risk. Now, we have another component, another cute thing, which is the baby. And what do you think about are the babies at risk for long-term complications? So those are the new studies that we published in my medical center, and let's take a look at them. Regarding the baby, we evaluated long-term neurological disease, long-term cardiovascular disease, long-term respiratory, and gastrointestinal disease. So let's start. We'll start with the neurological disease because those are the toughest. And this study was published in Early Human Development. It was published last year, and we evaluated patients with preeclampsia as compared to patients without preeclampsia. And as you can see here, we categorized our data according to no preeclampsia, mild preeclampsia, severe, and eclampsia. And as you can see here, the risk was significantly higher if the patient had preeclampsia as compared to patients without preeclampsia. The risk was 0.98 for any neuropsychiatric hospitalization of the offspring, It jumped to 1.1% if she had mild disease, 1.9 disease if she had severe disease, and 1.2 if she had eclampsia. You can see here that the sub-analysis, we found CP, higher rates of CP among patients with preeclampsia. And this is the Kaplan-Meier survival curve. You can see here, you can see here in the beige, patient with severe preeclampsia, and those are patients with eclampsia, which means that severe preeclampsia is actually a risk factor for long-term neurological disease of the offspring. As the disease is more severe, the risk is higher. You can see here preeclampsia in a multivariate analysis. This is the Cogs proportional hazard model. And here again, we control for maternal age, for gestational age, and for gestational diabetes mellitus. And if a patient had preeclampsia, the child, the offspring, was at a significant risk for long-term neurological disease, and the risk was 1.4 times higher. What about cardiovascular disease? This study was published in Pregnancy Hypertension in 2018, and again, we evaluated the risk for cardiovascular disease among the group of patients with no preeclampsia, mild, severe, and eclampsia. And you can see that the risk for cardiovascular morbidity of the offspring was significantly low, was very low if the patient did not have preeclampsia, but it jumped, and the p-value is less than 0.002. It jumped to 2.7% if the patient had eclampsia. And the risk for hypertension of the newborn was again statistically significant. You can see here that in the multivariate analysis, only the severe disease, severe preeclampsia or eclampsia, was noted as a risk factor for cardiovascular disease of the offspring, which is very similar to the neurological issue. What about respiratory disease? This study was just published in pediatric pulmonology. And here you can see the results of the study: no preeclampsia, mild preeclampsia, severe, and eclampsia. Let's see. You can see that basically a sub-analysis of asthma bronchiectasis was not statistically significant. You can see bronchiolitis, pneumonia, respiratory influenza. Like while we measure each disease separately, we couldn't find statistically significant results. But when we gathered all respiratory morbidity, we found out that patients with preeclampsia, the offspring, were at significant risk to be hospitalized due to respiratory pulmonologic disease. And the risk jumped significantly to 9.9% if the patient had eclampsia. It started from 5.7% if she didn't have eclampsia. And this is the Kaplan-Meier curve. You can see here no preeclampsia, mild disease, which acts very similar, which is very comparable to the other diseases. It seems that mild preeclampsia is not a risk factor, but take a look at this. Severe preeclampsia and eclampsia certainly pose a statistically significant risk for long-term disease of the offspring. And here it's regarding respiratory disease. And in the Cogs proportional hazard model, babies born to patients with preeclampsia were at 1.3 times higher risk for pulmonology or respiratory disease of the offspring. And lastly, gastrointestinal disease. And this study was published in Pregnancy Hypertension. It shows you that the mean follow-up period was 11 years. Mean follow-up, it's not that short. And you can see here, again, the disease was not statistically significant if the patient had mild preeclampsia, but if the patient had severe preeclampsia or eclampsia, their babies were at significant risk for long-term gastrointestinal disease. And you can see here the results. Basically, the rates of the diseases were very low, so we couldn't find any specific disease, but the total was 7.7% if she had severe preeclampsia or eclampsia, 5.5% if she didn't have preeclampsia. And this is the Cogs proportional hazard model, which showed that severe preeclampsia or eclampsia pose a risk for long-term gastrointestinal disease of the newborn. What are the hypotheses of the disease of the newborn? So first, adaptive responses to the preeclampsia may result in epigenetic changes that affect disease susceptibility later in life. The compromised fetal environment is a critical factor that can substantially affect the long-term health of the offspring. and the injury may be noted only later in life. So what did I show you here? I show you that preeclampsia is a gestational disease, but not only gestational disease. I showed you that preeclampsia is a significant risk factor, very, very significant for the mother, but also for the baby. And guess what? We don't like doctors. We don't like to go to doctors. When do we go to doctors? We go to doctors when we are toddlers. Then we go when we are pregnant because we have to. When we are toddlers, we go to get our vaccinations and stuff like that. And when we are pregnant, we go to the doctor. The third thing that we go to the doctor will be when we will be sick. So as obstetrician, we have a unique availability to screen patients, to do secondary prevention, to help our patient not only during the pregnancy, but also after the pregnancy. And we should be familiar with the fact, the family physician should be familiar with the facts, and our patients should be familiar with the fact that gestation complications are not only gestational complications, which means that pregnancy is actually a window of opportunity to detect diseases of the mother and child. Pregnancy complications are not only pregnancy complications, they pose risk for long-term complications. So preeclampsia is an independent risk factor for long-term morbidity of the mother and child. Surveillance is required following preeclampsia for early detection of long-term morbidity of both the mother and child. And we all must be familiar with the fact that for the mother, the risk is very critical. It's very significant. For our mothers, about 10% will be sick for cardiovascular disease. Luckily enough, in the newborns, the rates are very low because they're only newborns. I would like to thank you for your kind attention. This is the textbook that I published last year, a year before, the long-term impact of medical complication in pregnancy. It is divided to 18 chapters, half of them regarding the mother, half of them regarding the child, and they all focus on the fact that pregnancy is a window of opportunity to detect long-term complications for the mother and child. So next time, I hope we'll discuss it in frontal in India, which is my favorite country. I would like to thank you again for the kind invitation and see you soon. Thank you very much.
Thank you. Thank you. Thank you, Professor.
Thank you, Dr. Eyal. Over to the chairpersons.
Thank you, Professor Eyal, for that evidence-based, crisp talk on the later complications of preeclampsia to the mother as well as the baby. And we are very much impressed by your database. And you have a very good database, and you have followed up the women who had preeclampsia for a longer period. And what I wanted to ask is that, what is the intervention that you have done for the women who had preeclampsia in pregnancy, women as well as children, long term? Short term you have projected. What is the long term follow-up intervention that you have done?
Basically, we start not with the interventions, but with screening. And we offer it's written in every patient following GDM, just diabetes, and every patient following preeclampsia are summarized, the charts as statements regarding the thing that they must do. And as I said, the thing that they should do are very simple, but they should be in the focus of our attention for the prevention. So we offer them blood screening, 6 to 12 weeks postpartum, blood pressure screening, and then a yearly thereafter. It depends on, the guidelines are are not that strict now, but for critically, and we divide it for severe disease, because if the patient has eclampsia, we even offer echo, maternal echocardiogram, and obviously ECG. So it depends on the severity of the disease, but all our patients are encouraged to go to the primary care physician 6 to 12 weeks postpartum, and then we start with our follow-up, because the problem is that the patients are lost to follow-up, and when they come to you, they already have chronic hypertension, uncontrolled diabetes, and stuff like this. So we just do the dietary consultation, the blood pressure, and screening for gestation, screening for diabetes if they have other risk factors. Very simple.
So it's important that the advice we give for all women who deliver having had preeclampsia. No? I am talking about our population. We have to give them the detailed advice as to the need for follow-up and the chance for later development of cardiovascular events, stroke, and for the baby. And we can give them advice about lifestyle modification. And one thing again I wanted to ask is
the follow-up in Israel is with the primary care physician. So we did a lot of consultation and conferences with the primary care physician, family physician and pediatrician, because they help us to do it all properly.
If endothelial damage is common in preeclampsia as well as later development of atherosclerosis and cardiovascular events, could it be immunological? And maybe some mode of immunotherapy can evolve in pregnancy so that we can prevent later development of all these. I'm thinking, you know.
Maybe our data is epidemiological data. We didn't try interventions during pregnancy. We are trying to define if patients received aspirin, because many patients now receive aspirin. So the next studies will be whether patients with aspirin, whether aspirin improved the long-term outcome. But meanwhile, you're right, it might be helpful, but we don't have data regarding this.
There is one question, is the risk of stroke increased for mother in later life? That's what exactly it is said, no?
Yeah, it's all vascular diseases increase. Renovascular, cardiovascular, cerebrovascular, they are at risk. It is now a well-known data, like in meta-analysis from all over the world. And actually there are many studies from Scandinavia regarding the long-term effect of the vascular effect of preeclampsia.
All because of endothelial damage.
Yes.
And there is another question, what is the cause for GI morbidity? Gastrointestinal morbidity. Cause for gastrointestinal morbidity.
For the morbidity is for the baby. We think that the environment, the jeopardized environment might cause the insult. We don't know exactly, but the babies, the risk for the mothers are ophthalmic disease, cerebrovascular, they are all endothelial. For the babies, we have theories because they are like neurological disease. We don't know why. We have hypothesis, and our hypothesis is that the uterine environment is not as good as without preeclampsia. All the cytokines might cause it. We don't know.
Dr. Radha. Could be cytokines.
Dr. Radha.
Yes.
Dr. Radhaman, any comments?
Yes, sir. I would like to add one point, sir, because it is evidence that the action of SF51 lasts for several years, and the SF51 will inhibit the vascular endothelial growth factor exhibited by even the vessels of the choroid plexus, the thyroid, and also glomerular capillaries. The effect is actually white matter, the temporal and cerebral white matter changes are seen. And this is even we are able to detect by MRI long before the stroke or any cerebral vascular accidents occur. And because the thyroid vascularity is increased, these patients have high TSH and also they are more prone for they remain hypothyroid. And also because there is the glomerular capillaries are affected, there is a microalbuminuria and end-stage renal disease is common. So what we need to do for these patients are long-term follow-up is needed to detect the early diagnosis and treatment of hypertension, number one, and also microalbuminuria, so that actually physician awareness by the continuing medical education programs, and we need to give awareness to the patient about the lifestyle modifications about because it is seen that the weight gain after the first delivery with the preeclampsia, the chance of successive preeclampsia is more. That is, so they have to reduce the weight to pre-pregnant level. And also the triglyceride level. They have to this close monitoring about this. All these lifestyle modifications are needed, and early detection of treatment of hypertension and also proteinuria will reduce the complications. And another most important fact is there's impaired memory, and the cognitive impairment is also seen in postpartum patients. within 3 to 8 months. This is because again due to the changes in the temporal lobe and the cerebrum because of the vascular changes that occur in the brain. And this is the MRI is able to detect all these changes before this. Thank you, Dr. Eyal, for your elaborate discussion, and also about the GI problem, the fetus, actually what is the reason for it? Is again the vascularity that is affected or not?
As well as I said, you're absolutely right regarding the mother. In the mother cells, I mean, everything is clear. It's like the endothelial damage and the vascular damage. Regarding the baby, we think that it's the uterine environment which is jeopardized, and this will, as I said in my last slide, that actually it might be the environment might cause this those issues. We don't know if it's an adaptive response to the preeclampsia, which will result in epigenetic changes that affect disease susceptibility later in life, or the compromised fetal environment is critical factor that substantially affect the long-term health of the offspring, and perhaps the injury may be not notably only later in life and not as immediate outcome. That's what we thought.
Thank you.
So can I have a question? This preeclampsia is a multi-system disorder. The mirror image, the baby's multi-system is being affected. All the systems, GIT, respiratory and all. Does the weight gain after the newborn is being born has a relation to this morbidity? Our obese babies are having more of cardiovascular and such complications. That is, most of the babies overfed, such things. Has it got any relation?
Yes, definitely. When we combine risk factor, the outcome is worse. In all of our study, we control for obesity and diabetes because we know that obese babies, that babies born to obese patient and babies born to diabetic patient have cardiovascular, endocrinological issues, but we control for those issues. And even after controlling for those complications, preeclampsia was noted as an independent risk factor for long-term morbidity of the offspring. But we know that those factors go together.
One more question in the chat box is, has gestational hypertension has got the same implications as preeclampsia?
There is a 5 to 10%.
No. Regarding, it's a very good question. First of all, gestational hypertension was not noted as a risk factor for long-term complication of the baby. Regarding the mother, it was a weaker risk factor. And as I said, regarding the babies, only severe preeclampsia and eclampsia were noted as risk factors for long-term complications of the babies, unlike the mother, in which all the gestational complications posed risk for long-term cardiovascular disease.
Thank you, sir.
Thank you. Thank you, Professor Eyal. Thank you very much.
Thank you very much.
Thank you. Rajesh. Smita. Smita, take over.
Thank you, Professor Eyal, for that extensive talk. Thank you, Madam Prasna Kumari, Madam Radhamani, Madam, and Nishi, Madam, for having your inputs as chairpersons. We'll move on to the next talk. We have a talk on preventing stillbirth by Professor Alexander Haezel. The chairpersons for this session are Professor N.S. Sridevi, Madam, Dr. Chellama V.K., Dr. Lalitambika, Madam. Dr. Sridevi, she's former Professor and HOD of Calicut Medical College. Now she is Professor and HOD at Pushpagiri Medical College. She was the past President of Calicut Society and past President of Kerala Federation of Gynecology. Professor Chellama, Madam, she is the Professor and HOD at KMCT Medical College, Calicut. She was the former Professor and Unit Head at Government Medical College, Alapura and Calicut. She was past President CAFOG and past President and Secretary of Calicut ONG Society. She is past Secretary of Calicut and Chairperson of IMA Women's Wing Calicut during the year 15-16. Professor Lalitambika, Madam is Professor, Department of OBG at Government Medical College, Alapura. She is the past President of Kerala Federation of Gynecology and President of Alapura ONG Society. Welcome you, madams, to chair this session. I invite Dr. Chellamma Madam to give an introduction of our speaker. Over to you, Madam.
Good evening. Am I audible?
Yes, Madam.
Okay. So it's with great privilege I am introducing Professor Alexander E.P. Haezel and to this audience of the international conference. Dr. Alexander is a professor of obstetrics and honorary consultant, University of Manchester and St. Mary's Hospital, Manchester, and Maternal and Fetal Health Research Center, University of Manchester. He is also the clinical director of Tommy's Research Center. He bagged the prestigious Research Star Award of Outstanding Contributions to Stillbirth Research Star Regency Foundation in February 2016, and I think he is the most eligible person to talk on stillbirth today. And also he bagged the William Blair Bell Memorial Lectureship, Royal College of Obstetricians and Gynecologists in 2011. He is having 205 peer-reviewed publications to his credit. Thank you, and welcome Professor Alexander E.P. Haezel.
I request Professor Sridevi Madam to have a few words about our topic. Sridevi Madam.
Hello. Hello. Can you hear me? Yes. Yes. Definitely. Good evening to all of you. Definitely, the topic is stillbirth. Not a very pleasant topic for all the audience, all the obstetricians. Stillbirth is always a nightmare to the obstetrician, not only to the obstetrician, but also to the family, the treating woman and the treating lady and the family. According to the definition, stillbirth is birth of death of a baby after 22 weeks. Another definition is, according to Cochrane, it is 22 weeks. Other definitions, they say it is at 20 weeks or after that. Maybe antepartum or intrapartum. And are there any way by which we can, antenatal interventions are there to prevent stillbirth to some extent? I don't think it will be possible to prevent 100% of the stillbirth. So let us hear from Sir about stillbirth, how to prevent it. That is the topic for today.
Good afternoon and good evening to those of you in India. Thank you very much for the invitation to speak to everyone today. Can I just check, can everyone hear me okay?
Yeah.
Wonderful. So I'm just going to talk about what can research tell us about stillbirth prevention. As the esteemed madam said, I am the Professor of Obstetrics at the University of Manchester, and I have a long-standing interest in stillbirth. So in terms of the scale of the problem, it's very difficult to put an exact number on it, but the WHO estimated that in 2009, there were 2.6 million stillbirths globally per year after 28 weeks of gestation, 98% of which occur in low and middle income countries. But only 2% of stillbirths were counted through robust registration systems. So a lot of those estimates are highly variable. And so consequently, this estimate could have been as high as 3.8 million per year. And this schematic really emphasizes the importance of both sub-Saharan Africa and South Asia in the global stillbirth figures. And sadly, overall, India in this report from the WHO had a stillbirth rate that was between 50 and 25 per 1,000 births. And I guess the first question is, why should we, as obstetricians, really be wanting to address stillbirth? Well, not only from a moral perspective, but actually also to limit the psychological and emotional distress that women and their families feel But also because of the stigma that surrounds stillbirth, actually there's an increased risk of family breakdown if a woman experiences a stillbirth, of abandonment and abuse. There's increased healthcare costs. It actually costs more money to look after a mum who's had a stillbirth, and in fact, often in subsequent pregnancies, because those women have additional care, this costs more money. And women may have reduced earnings from employment, they have maternity and paternity leave, and healthcare expenses. So actually, there's a considerable social and economic imperative to preventing stillbirth as well. So in terms of how we might go about preventing stillbirth, well, actually, what we really want to do is to have a good understanding of risk factors and causes, and that really comes from having investigations after a baby dies and robust perinatal audit, which I know is something that's been introduced and developed over the years. For people like me to conduct research and then think about interventions, that then gives us we can implement those interventions and then see if they prevent stillbirth, and that goes round and round in a virtuous cycle. So what do we know about stillbirth in high-income countries? Well, there's a very big variation in across high-income countries. So the fastest decline in rates is actually the Netherlands, that has gone down at nearly 7% per year between 2000 and 2015. And the UK actually, where I practice clinically, hasn't done all that well. Between 2000 and 2015, actually, we went down at 1.4% per year, which is in the lowest third of the rate of declines in high-income countries. And not only that, when we look at the UK, this is a red, amber, green chart. And so green is a good stillbirth rate, if you like. It's lower than the national average, and red is higher than the national average. And you can see that the distribution of stillbirth across the UK is not equal. And particularly where I work here in Manchester, you can see in this report, sadly, we were all in red. And so that's partly because of the social factors that go along with stillbirth. So if we're thinking about how we can identify risk factors, well, in an ideal world, we would do a prospective cohort study of the whole population to study the outcome of interest. Now, when you have an infrequent outcome like stillbirth, to identify 291 women with late stillbirth in the UK would require somewhere around about over 100,000 participants. And even to do that in India, where some areas have much higher stillbirth rates, you would still need in excess of 25 or 30,000 participants. And that is a huge undertaking for research. So the alternative approach is to apply a case control design, and then you need to try and minimize the bias by ensuring that the study was conducted in the same population at the same time. And these are some of the risk factors over the years that have been identified for stillbirth. And again, most of these studies are from high-income countries. One of the real challenges in stillbirth research is there is a disconnect with 98% of stillbirths happening in lower middle-income countries and 98% of research happening in high-income countries. So what we really need to do is to move stillbirth research out of high-income countries into high-burden countries as a matter of urgency. So in high-income countries, one of the real challenges we face in obstetrics is that the majority of stillbirth actually occurs in women with no risk factors. And the majority of risk factors that there are have only moderately increased risk. And I will go and talk about these a little more later on in the presentation. But even diabetes and hypertension really increase the risk between 2- and 3-fold. Cigarette smoking increases by 1.3 to 1.6. And I noticed that you've already, Gordon has already spoken to us about the importance of trying to detect fetal growth restriction. because in high income country settings, really being small for gestational age is the biggest single risk factor. But also in red, I've highlighted that a previous stillbirth actually places you at a woman at a 5 times increased risk of a subsequent stillbirth. And this really is a very high risk group. So these modern case control studies have either been done in Auckland, the Auckland stillbirth study, MINUS, which is the Midland and North of England stillbirth study, which was a study I coordinated, the Sydney stillbirth study, and also an international study by the STARS consortium. So roughly speaking, all of these studies have included late stillbirths after 28 weeks gestation. The controls are recruited at the same gestation and with ongoing singleton pregnancies. These didn't include congenital abnormalities. In the introduction, the chair quite rightly said it's not realistic to have a stillbirth rate. We're never going to prevent all stillbirths, but we're talking here about non-anomalous singleton stillbirths. Women had to be over 16 years of age and able to give informed consent. And the data were collected using researcher-administered questionnaires. And so this is an example of what we found from MINUS and the population attributable risk. You can see again, the biggest risk factor in our population was being small for gestational age, which accounts for approximately 45% of the exposure to stillbirth, being nulliparous or multiparous. Smoking during pregnancy remains the thing that we can most easily do something about. Of a growing problem in the UK and also other low burden settings is the role of obesity. And then we've also found that going to sleep in a supine position increases the risk of late stillbirth.
No, I know. We used to tell Amit.
When we try and work out whether these things are causative, we can apply these Bradford Hill criteria. You can see here there are 9 different criteria that this epidemiologist suggested for trying to understand if an observation might be causal. There is certainly a suggestion that when mums lay supine, there is a change in fetal behaviour. Studies have tended to show the same thing, and there are biologically plausible mechanisms for why this might be the case. And so here on this side, I've just shown that this is the odds ratios that the different studies have shown for going to sleep in a supine position. So between 2 and 6-fold increased risk of late stillbirth. And when that's adjusted for different maternal characteristics, it's between a 2 and 3-fold difference. And whether this is biologically plausible, well, we know that when a mum lays supine, there's a reduction in maternal cardiac output and also fetal oxygen saturation. And if we think how we manage mums in labour, one of the first things that we do in the presence of a fetal bradycardia or a pathological CTG is to turn mums off a supine position if that's how they are laid. And we also were able to look in, by doing an individual patient data meta-analysis, we're able to see that actually mums who went to sleep supine had an increased risk of a small for gestational age birth and actually 144 grams smaller baby. So again, there seems to be some biological plausibility to this observation. Another risk factor for stillbirth, which is perhaps a bit more contentious, is about awareness of fetal movements. And these are data from the STARS study that show that women who had a stillbirth, when they were interviewed, said that they were less likely to have been asked to be aware about their movements in pregnancy and consequently hadn't kept track of their baby's movements. And here you can see that babies' movements were reported by mums that had a stillbirth to be much less frequent. A high proportion of them reported that babies' movements were often less, so 40%, and particularly the frequency decreased. The problem with reduced movements is that 8.4% of women who had healthy live-born babies also reported a reduction in fetal movement. So it is not a very specific sign. And when we looked at minus data, we see the opposite is also true. So when a baby has increasing strength of movements or increasing frequency of movements, the risk of stillbirth becomes very, very much lower. So if a mother reports to us that her baby is moving normally, we can be very reassured. Interestingly, also hiccups, which I think increasingly there is a lot of misinformation about on the internet, is that they seem to be protective. So if a mum is feeling baby having a lot of hiccups, that is not associated with an increased risk of stillbirth. So again, is there any science that we can look at whether there's a link between reduced movements and stillbirth? Well, when we looked at the placentas from women who came with reduced movements, you can see that actually the reduced movements here shown in red had increased numbers of syncytial knots, which are these aggregates of dysfunctional nuclei in the placenta compared to normal healthy tissue. And they actually, the villi were less vascular. They had fewer blood vessels in, which suggests that there may be, in some women, underlying placental pathology. And interesting, this has now also been shown in 2 other populations. If we then move on to physiology and we look at the transport of system A, which is an amino acid that we can measure by, we can use a radio labeled synthetic amino acid, you can see that healthy pregnancies have the greatest take-up of the amino acid, followed by a drop in women who had reduced movements and a further drop in women with reduced movements that had a poor outcome. So there does appear to be some scientific basis that this symptom might be associated with placental dysfunction. One of the biggest risk factors that's changing as population changes is that of maternal age. So extremes of maternal age are associated with stillbirth. And of particular interest in the UK is advanced maternal age. So our childbearing population is changing. So in 1980, when I was 4, only 6% of mothers were aged over the age of 35 and 1% were over the age of 40. In 2010, when I was a senior trainee, 20% of women were over the age of 35 and 4% of mothers are over the age of 40. This has continued to increase. It's now 24% of women over the age of 35 and 6% of women over the age of 40. To try and drill down into some of this association, we did a large meta-analysis of observational studies of over 44 million births. And mums who were over the age of 40 have a 1.75 increased risk of stillbirth. And interestingly, that did not differ with geographical region or year of study. The observation was remarkably consistent. And when we did meta-regression, you can see here that actually there appeared to be a relationship that increasing rates of stillbirth with increasing maternal age. And actually the R squared was pretty high. It was 0.61. So I think this is a relationship that we do need to take very seriously. And again, is this a biologically plausible relationship? So we did a study looking at, we did a cohort study recruiting women over the age of 40, but as a comparison group, we had women from 35 to 40 and under 30. And again, excuse me, actually our women over the age of 40 had a 1 in 43 rate of stillbirth, which again is consistent with that higher observation. here you can see in these graphs, women over the age of 40 had a higher placental weight and consequently a lower fetal placental weight ratio, suggesting reduced placental insufficiency. And they also had more syncytial knots and fewer proliferating cells in the placenta, shown here by the Ki67 staining here. So this suggests that their placentas are structurally different. And again, actually, they seem to behave differently when we look at amino acid uptake again. So mums over the age of 40 actually had a more efficient placenta than women of younger ages. And so we hypothesize that this really tells us that to achieve the same outcome, placentas in women over the age of 40 are having to work harder. And again, the arterial function in women changed, and this may be as a result of maternal aging. And lastly, I just wanted to touch upon social and behavioural factors. Women in the most deprived quintile have an adjusted odds ratio of stillbirth of 3. So if you are in the most deprived quintile in the UK, your rate of stillbirth is 3 times higher. This was also true for women who were unemployed, who had high levels of social stress, and had, interestingly, refused to answer the question relating to intimate partner violence. So, and we believe this association may be because these were women who were subject to intimate partner violence but didn't disclose it, and so as a consequence we could not provide them with any help. Whereas if they disclosed intimate partner violence in the study, then we were able to intervene. And this really fits. If you remember the relationship I showed you across the UK, that the stillbirth rates were uneven. This graph shows the distribution of children who were impoverished in the UK in 2009, with the dark being worse, and again the rates of unemployment. And you can see actually the distribution of unemployment and poverty was not dissimilar to the rates of stillbirth in the UK. And it's very tempting when we're looking at this to think, well, this doesn't really, does this really pertain to us? What can we do with this? And actually, what I would say to you is that the studies that I've been able, the recent studies from South Asia that have been published show huge overlap with the risk factors for stillbirth that I've just described to you. So a lack of antenatal care, hypertensive disorders of pregnancy that I know Professor Walker's already spoken to you about, reduced movements, babies being small, and also women who had a previous stillbirth. And the way we deliver care may also have an impact. This paper by Raki Dandona from Bihar showed again the risk factors were common with those just reported in the systematic review, but also deferred delivery. So women are being sent home from delivery unit when they're in early labour, excessive force applied at delivery, and also birth at home or birth in private facilities. So just to summarise this section, I think observational data has shown many different associations with stillbirth. And we think that most of these impact via the placenta and consequently fetal growth. But some important risk factors are not within the scope of maternity care. So, we're not going to start to take on, societal poverty, but we might be able to ameliorate their effects by having accessible maternity services. And what we then need to do is to develop and test strategies to reduce stillbirth in women with risk factors. So I just want to touch on that, as I said before, stillbirth is sufficiently infrequent to be difficult to study. And again, intervention gives us a very statistically difficult problem relating to statistical power. So to detect a 10% fall in stillbirth from 4 per 1,000 to 3.6 per 1,000, we would need 371,400 women in each arm of a trial. And that's not even accounting for cluster, excuse me, into cluster variation, which would actually push this number up. But if we want to detect a 10% increase in other common and potentially undesirable outcomes, like induction of labour, require many fewer samples. So to show a 10% increase in induction of labour, I only need 3,763 participants. So a trial to demonstrate a 10% reduction in stillbirth could easily demonstrate a 1% increase in induction of labour. And part of this, I think, has been shown in the AFFIRM study, which was a stepped wedge cluster trial based in the UK, which combined as an intervention information for women and education for clinicians about fetal movements and standardised management of women presenting to hospital. And different units were randomised to when they started the intervention. And so it enabled the intervention to be rolled out. Now, the first thing to say is that the control group weren't doing nothing. They had the leaflet was based on the Royal College of Obstetricians and Gynecologists information and their guideline that's current. And the management was effectively in line with what the RCOG guidance recommends. In addition to that, the AFFIRM study were asked to contact maternity units if they were ever concerned about their maternity units, and there was no gestation specified. Everyone had an ultrasound scan or a scan for fetal growth, and induction of labour was considered for women more than 40 weeks on their first presentation with reduced movements, or over 37 weeks, so women with recurrent reduced movements. So this was a very big study. It had information for a large number of births. 227,000 plus women in the intervention period, and just about 158,000 in the control. And the intention to treat analysis showed no statistically significant difference in the number of stillbirths over 24 weeks, which is the threshold for UK legislation. It overall showed a 10% reduction, but because of this wide confidence intervals here, that could be 5 fewer stillbirths, but it could be as many as 11 fewer, or up to 3 more. When the analysis was restricted to units who definitely did the intervention, again, there appeared to be a reduction, but it didn't achieve statistical significance. However, what did achieve statistical significance is evidence that we could do things that were potentially harmful. So there was a 5% increase in induction of labour. There was a reduction in spontaneous vaginal delivery. There was a 9% increase in caesarean section. And a 12% increase in the babies admitted to neonatal unit for more than 48 hours. There was, however, a statistically significant reduction in the babies born small for gestational age. So the take-home message from this, I think, is that we need to remember any initiative that may aims to reduce stillbirth may have important knock-on consequences that we need to be very careful to evaluate. This again is also shown in this very nice randomized control trial called the 35 to 39 study that Gordon Smith, who's already spoken to you, was involved with. And this study offered induction of labour at 39 weeks gestation to all women over the age of 35. And the primary outcome, this was never powered to prevent stillbirth, but it looked at whether we would increase the caesarean section rate. And actually what they found, the caesarean section rate was absolutely unchanged in women who had induction of labour at 39 weeks gestation. And if anything, this appeared to save money. So what happens if you look at this in the real world? Well, this is English hospital audit data that showed in 77,000 women that 33% of women had an induction of labour at 40 weeks. And women who had induction of labour had a 66% lower incidence of perinatal death and a lower risk of meconium aspiration. But they did have an increased 6% increased risk of instrumental vaginal delivery and a 5% increased risk in caesarean section. And it gave a very high number needed to treat to prevent one perinatal death. We would have to induce 562 women. If we restrict the intervention to a higher risk group, so women over the age of 40, we would still have a number needed to treat of about 200. So I just want to touch on trying to put some of these initiatives together in something called the Saving Babies Lives Care Bundle. And this was launched by NHS England in 2015, and pilots started doing this in March 2014. And it combined 4 key elements: reducing smoking and smoking exposure in pregnancy, screening babies that are small, addressing reduced movements, and monitoring babies more effectively in labour. And you can see that actually, so we've red, amber, green this. So green is if hospitals were doing more than 75% of the care bundle already. Orange is if they were doing between 50 and 75% of the elements, and red if they were doing fewer than 50% of the elements. And you can see that over the period of implementation, hospitals increased the amount of the care bundle they were implementing. And we also saw that over time, the stillbirth rate changed. It fell from 4.14 per thousand to 3.3 per thousand, and that's a reduction of 20%. Again, though, we saw some concerning changes in the secondary outcomes. So things like increased risk of preterm birth, an increased risk of an elective caesarean section and emergency caesarean section, and a significant increase in induction of labour. So I just want to touch on one last strategy that I think is very definitely undervalued, and that's perinatal audit. Because understanding why babies die in our units is critical to prevent stillbirth. We need to make sure that we investigate why a baby died appropriately, and we can use different tools. So perinatal audit to identify conditions that are associated with stillbirth, and also confidential inquiries to make sure that the care we give is optimal. So in a confidential inquiry, you anonymise all the case records and people who are not involved in the care evaluate it. And using that approach, around a quarter of cases have care that is not in line with our unit guidelines. And ultimately, perinatal audit enables us to develop relevant local strategies. So all of the things I've said to you today, you may very well know with your local knowledge that that might have very little impact upon your stillbirth rates. And that's because your local knowledge is imperative in improving stillbirths in your setting. But there's evidence in multiple settings that perinatal audit reduces stillbirth. So this is data from New Zealand. And you can see they brought in robust perinatal audit in 2009. And they saw a year-on-year drop for the subsequent 4 years since their perinatal audit began. So just to bring everything together, in conclusion, we do need to address our stillbirth rates alongside our other challenges in maternity care. This isn't the only show in town, but if we reduce stillbirth rates, we're also likely going to reduce perinatal death rates, and particularly in high burden settings, that may also have benefit in terms of reducing maternal death rates as well. But there are real challenges in getting informative data, and we need to be aware that we might change other important secondary outcomes. We shouldn't try and recommend that medical solutions are going to provide the complete solution, because they aren't, and there's a very important role for perinatal audit and research. And our changes, I think, need to be incorporated iteratively and in a constant effort to improve quality for women and their babies. I just want to take a moment to thank everybody who particularly participated in the minor study and the Saving Babies Lives Care Bundle evaluation. that have underpinned a lot of the work that we have done in this area. And thank you very much for your attention.
Thank you, sir.
Thank you.
Hello.
Hello.
Word from the chairpersons.
Hello. Am I audible?
Yes, madam.
Thank you, Professor Alexander Haezel, for elaborating various causes of stillbirth in detail, including simple things which we may not observe, like maternal position on going to sleep, social and behavioral factors like stress, partner violence, importance of educating women about observing fetal movement, and reporting in change in pattern rather than absolute fetal movement count as we usually advise. So any woman who is experiencing a change in movement pattern, we should give more importance and monitor them more carefully. He also discussed the various measures to reduce stillbirth. In Kerala, though the antenatal care is very good, still we get many unexpected or unexplained stillbirths. And we find on analysis or an audit, perinatal audit, we have observed that many of them are undetected fetal growth restrictions. Though the fetal weight is more than 10 centile, when we follow the growth chart, we find they have a fall in weight percentile. Maybe it started with 70th centile and later on it has fallen to 20th or 30th centile. And such babies are also at risk of unexplained perinatal death. So that is one of the important factors cause we find in Kerala, in spite of good antenatal care. So rather than the textbook definition of 10 centile as IUGR, we should also consider the growth rate or growth pattern to prevent so-called unexpected or perinatal death without any cause. Thank you, sir, for such an elaborate talk on a very common, and as Madam has already said, it's a nightmare for all the obstetricians as well as the patients, unexplained perinatal death. Thank you, sir.
Professor Alexander. Hello.
Hi.
Hi. I'm Dr. Chellamma. It was an excellent presentation and its studies were very good. So in your observation study, you mentioned that in 81% of cases, there was no risk factors. Isn't it? Hello?
Yes. Hello.
According to the INGOD classification, we are looking for the maternal causes, genetic, placental, obstetric causes, everything we are taking. So in this case, 81% of cases, there was no risk factors. My question is, how will you follow up these patients and how will you manage these patients in the next pregnancy? Because there is no risk factors earlier.
Thank you, Dr. Chellamma. So I think the first thing to say is they said that was 81% didn't have risk factors at booking. So they weren't older or diabetic or hypertensive. But actually, so for some of those women, they developed risk factors through their pregnancy. So, you know, they may have developed growth restriction. I think in our experience, so we have a specialist pregnancy after loss clinic. I think the women who have an unexplained stillbirth, so who have no risk factors, are some of the hardest to look after because we don't have something definite that we're looking at. So we can't say to them, your baby is growing well, it's not going to die, or, you know, your blood pressure is very good now. So I think they can be very difficult to look after. I think with really good investigation, we would say fewer than 1 in 5 stillbirths are unexplained.
Okay. And also, I think we should follow up with careful antenatal, both antenatal care and also about their serial ultrasound and also about asking about the checking for the fetal movement count. Another thing is that last year in 2020, there was a US-based large study. They studied at 455 stillbirth. They found that 8 gestational diabetes mellitus DDM is one of the most important. Without this gestational diabetes mellitus, they found that after 37 weeks of gestation, GDM causes more stillbirths. So what is your comment about that? Diabetes and stillbirth.
I agree with that study. We found, we looked in minus at women who should have had an oral glucose tolerance test and didn't. And we found that those women that met the criteria, but for whatever reason did not get the test, had a higher risk of stillbirth. And we also found that women who had particularly who had a high fasting level of glucose, but not a 2-hour high level, also had an increased risk of stillbirth. So I think gestational diabetes is an important risk factor. Our studies suggested that if you treat it well and you control the diabetes, actually the outcome was as good as women without gestational diabetes. But obviously we have to make a diagnosis before we can manage it properly.
Thank you. And another problem we face after stillbirth is, one is legal issues, and second one is the postpartum depression for the mother. So how will you, what is your comment about that? How will you follow that?
So,
I think in UK also legal issues are very high. And
so we're very fortunate in that we have a very good, we have a bereavement specialist midwife, and she and I work together to provide support for those mums, and that to some extent is able to address some of the problems with depression. But that's you know, that
I think
that's
RCLE has come up with some guidelines for that.
yeah.
Okay, thank you very much.
Hello. Hello, Doctor.
Hello,
Dr. Alexander. I'm Dr. Sridevi. Placental function is an important factor in these cases. You have already mentioned, and it is theoretically proved, increased placental abnormalities. So, function of the placenta, any assessment, any specific measures to record this placental function?
So at the moment, no, but I am hopeful that in our professional lifetimes, I think, you know, we are now beginning to measure PLGF, S-split ratios for preeclampsia.
Yeah.
I think that we should be able to develop, you know, a placental blood function test in the same way that we have renal function and liver function tests. We're not there yet, but I'm aware of several quite interesting studies looking at proteins that the placenta makes. And maybe that, in conjunction with ultrasound, might be able to guide our practice in the future.
Okay. Thank you for that. Thank you, sir.
Thank you. Thank you very much, Professor Alexander. A nice presentation.
Thank you, Professor Alexander, for the nice talk. Thank you, the chairpersons, Sridevi Madam, Chelama Madam, and Ledambika Madam. Without wasting much time, we'll go to our final session. Our next talk is on the impact of COVID-19 on the maternal and perinatal health by Professor Patrick Obrien. The chairpersons for the session are Dr. Jaydeep Tang, Dr. Ajit S, and Dr. Shaijas Nayak. Dr. Jaydeep Tang is the current Honorable Secretary General of FOGSI. He is the President, Mumbai Obstetrics and Gynecological Society. He is the Secretary, Asia Oceania Federation of Obstetrics and Gynecology. And is a member of FIGO Committee for Safe Abortion. Dr. Ajit S is the Professor and HOD Department of OBG, Government Medical College, Kannur. past Vice President KFO, past President of Kannur ONG Society, past Chairperson of Research Committee of Kerala Federation of Obstetrics and Gynecology. Dr. Shaijas is the Chairperson-elect of Midlife Management Committee of FOXI and Research Committee of IFO. South Zone Coordinator for Breast Disorders and Public Awareness Committee of FOXI. Is the President, Kannur Medical ONG Society. Is a fertility specialist at RMC IVF Center, Kannur. I welcome all chairpersons for the session, and I invite Dr. Jaydeep Tang to introduce our speaker.
Thank you very much, Dr. Ravi. I hope I am audible.
Yes, sir.
Yep, thank you. So first, I'd like to thank Dr. P.K. Shekaran, sir, the organizing chair of this quite wonderful CME, for putting together this absolutely fantastic evening and afternoon of wonderful deliberations by absolutely brilliant faculty. I'd also like to thank the President and the Secretary of the Calicut Society, Dr. Jyoti Chandran, and my good friend Subhash, and of course the President and Secretary General of KFOG, Dr. Ambujam, Dr. Venugopal, the Joint Secretaries, Dr. Smita and Dr. Ravi, and the Academic Committee led by Sonalika and Suresh. COVID-19 is of course upended our lives, but at the same time, it's really a relatively recent conditions, which means that oftentimes we have to deal with situations where evidence is scanty or even non-existent. There has been a stunning pace of publication and knowledge gathering in a very compressed period of time, but one wonders whether we can hold the management of COVID-19, particularly in relation to pregnancy and the perinatal period, to the same stringent standards of evidence that we are used to all these years. And to talk about COVID-19 and its impact on maternal and perinatal health, I'm very happy to introduce Pat. It's always such a pleasure listening to Pat. He's an extremely articulate and erudite speaker. He is a consultant in obstetrics and gynecology at the University College London Hospitals, and also a vice president for membership at the RCOG. At the University College, he spent time as divisional clinical director for women's health and governance lead. He is a patron of the charity Safe Hands for Mothers, which works to promote women's health in low-income countries. Pat specializes in maternal medicine and high-risk obstetrics, and his areas of interest are the use of misoprostol in ONG, thrombophilia, cardiac disease in pregnancies, and the effects of obesity on pregnancy. He also works ad hoc as an obstetric advisor with BBC Television. Pat, I've been watching Doc Martin, the BBC series now, and I wonder whether you had a role to play in the episodes where they showed deliveries happening all over the Cornish countryside. His wife is a professor of fetal medicine, and he's of course got several publications to his credit. Pat, we are eagerly waiting to hear you, and I must say this must be one of those rare years where you haven't visited India. So we look forward to you visiting India very soon again. The floor is all yours, Pat.
Thank you very much, Jaydeep. I'm just going to share my screen now. It's a pleasure to be attending virtually. As you say, I'd much prefer to be attending in reality. But that's not going to happen. Maybe this year, maybe this coming year with a bit of luck. As I said, I've been to India many times and I really miss being there and seeing all my friends there. But it's a great pleasure to be involved in this conference. So thank you very much indeed for having me. Now, in the next sort of 30 minutes, I'm going to talk about COVID, and there's a lot to cover. So it's a bit of a whistle-stop tour. But I'm going to start by just going back to this paper that we published in the British Medical Journal back in June. And this was led by Marion Knight's group and called UCOS. And that's the UK Obstetric Surveillance System. And that's basically a system set up that looks at rare but important outcomes in maternity. And actually this system was set up from the time that we've been working on the swine flu pandemic. So basically this was sitting on the shelf waiting to be taken down and dusted off as soon as the COVID pandemic came along. So in this study, which included all the maternity hospitals, maternity units in the United Kingdom, I'll show you the data from it in a second. And then we used those data to publish in Lancet eClinical Medicine in July, a systematic review and meta-analysis, giving all the data in all the world literature at that stage. And what do we find? Well, you're probably pretty familiar with this now. First of all, in both meta-analysis and the UCOS study, Black, Asian, and minority ethnic groups were overrepresented, as were obese and overweight people, as were those with pre-existing comorbidities, as you might expect. And in terms of complications, there was a suggestion of possibly a slightly higher admission rate to intensive care, maybe of intubation, and thankfully maternal mortality seemed to be pretty low. And a fairly strong suggestion that your chances of being admitted to ICU were higher if you had pre-existing comorbidities or if you're age over 35. Nothing particularly surprising about that, I guess, in the sense that it mapped pretty well onto what was being reported in people that were not pregnant. So it was quite reassuring in that sense. More recently, in September, we have this from the WHO group, what's called a living systematic review and meta-analysis. What does that mean? Well, living review means that they constantly update it as new good quality studies become available. So this is of great value. So I'm sure they'll be publishing updates on this regularly, and this is the one to watch, really. And again, they found a suggestion, only a suggestion, that pregnant women are slightly more likely to be admitted to intensive care if they're seriously unwell with COVID, and similar findings from an American study as well. So the conclusions to that point were that, number one, the risk factors for having severe COVID are similar in pregnant women to people who are not pregnant. Number two, in general, when you get pregnant, when you get COVID infection during pregnancy, it does not seem to be any worse when you compare to non-pregnant women of similar age, although maybe a suggestion from the data that admission to intensive care is a bit more likely, particularly in the last trimester. And there was a suggestion at that point that the risks of preterm birth might be increased and the chances of being delivered by cesarean section are increased. Notable, even at that point, that 80% of all preterm births were iatrogenic rather than spontaneous onset of preterm labor. And at that point as well, quite reassuring that few of these babies, of these mothers, were infected, and even of those that were infected, very few had significant illness. Now, this is hot off the press, in fact, not even published or peer-reviewed yet, so that's why I put it right at the end. So this non-peer-reviewed, so preprint version, was released just last Tuesday, as I say, not yet published. This is again an update from the UCOS group, so hopefully will be published soon. But you can access it if you want on that link there. And what they find, so again, this is looking at all 194 maternity units in the United Kingdom over a 6-month period that included the first wave, the first peak of the pandemic here in the United Kingdom. Just over 1,100 women that were admitted to hospital with COVID. Now, bear in mind the group of women that we're talking about here. These are women who were admitted to hospital and tested positive for COVID. That does not mean that they had the disease, the illness, or symptoms. They may have come in just in labor. And nowadays we test everybody who's admitted for the virus, SARS virus, and these are women who tested positive. So these women are divided into those who had symptoms of COVID, which is about 2/3, and about 1/3 that were asymptomatic and just happened to be screened positive. And basically, of that number testing positive translates into about 3 per 1,000 maternities. So still a small proportion of our pregnant women, bearing in mind that there's a lot of women getting COVID out there in the community are still not being tested. These are the data from March up to early September. And you can see that the big first wave that came in March and April and then went right down during August, and it's gone right up again. And the levels are higher now, I think, than they were in March, April, but we don't have robust data for me to show you just yet. Blue are symptomatic and brown are asymptomatic. And the reason that the majority were symptomatic early on was simply that we didn't have access to that many tests. So we were testing only those who were symptomatic. Whereas now we have universal testing, so the proportions have changed significantly. And these unpublished data reflect what the earlier studies have shown. In other words, BAME women are overrepresented. The control here is a historic control taken from UCOS data of pregnant women that obviously did not have COVID. compared with the symptomatic COVID group from this most recent study. Overweight are overrepresented as well, as are obese, as are those with comorbidities. And a suggestion emerging that the particular comorbidities that increase your risk are respiratory, mainly asthma, and hypertension. What about the outcomes for these women? So again, a sort of firming up of this idea that ICU admission is more common when you have COVID and you're pregnant, especially in the last trimester. Deaths, I will come back to in a minute. There's some better data on this. Iatrogenic preterm birth, less than 37 weeks, much more common, but spontaneous preterm birth, not more common. Okay, so bearing in mind, there are early suggestions that women might be more likely to go into spontaneous preterm birth if they had COVID or bad COVID. That does not seem to be the case. And stillbirths, I'll come back to in 1 second as well. And just to go back there, cesarean section, about twice as common in symptomatic COVID women compared to controls. Now, meanwhile, back at the shop floor, there were a lot of kind of logistic and practical problems associated with the COVID pandemic. So we had more or less the same number of pregnant women coming through, of course, but especially in the early days, far fewer staff. People off through sickness and self-isolation, people redeployed. In the RCOG, we carried out during the lull between the peaks, we carried out a survey that showed that most units redeployed obstetricians from the front line on the labour ward to help out in intensive care in the medical wards. Having said that, we had some extra gynecologists because so many of the gynecology elective lists were cancelled. So a lot fewer staff, but the same number of pregnant women. Another practical issue, you know yourselves that fever in labour is quite a common thing for all sorts of reasons. And of course, in the early days, especially when we didn't have rapid testing, and we've only recently got access to widespread rapid testing, if somebody had a fever, we do the swab, and we wouldn't get the result for 24 or 48 hours. So that woman had to be treated as if she was COVID positive. So we had to wear the PPE, no swapping of staff. Women had to be cohorted into those with fever and those without, etc., etc. So a major issue. The other issue, which I'm sure was reflected in just about every country around the world, was the massive anxiety among clinical staff about PPE. And we didn't know at what stage the risk was greatest to us, to midwives, doctors, and so on. Was the first stage a risk? Probably not. What about when the woman is pushing and shouting, particularly in the second stage? Probably not, probably more of a risk from droplet spread, so you need a barrier protection. In the early days, I hadn't even heard about an aerosol generating procedure. I had to read all about it. Is Entonox an aerosol generating procedure? We didn't know at the start. Now we know that it is not. There were issues around neonatal resuscitation. If the mother was positive, the neonatal team would come in expecting that they might need to intubate the baby, wearing full PPE. Meanwhile, the poor midwife who had been with the woman for the last 12 hours was just wearing a mask and a visor. So lots of tensions there. And then the issue about cesarean section. If you needed to do a category 1 cesarean section, if you need to don all the PPE for a woman having a general anesthetic, it might take longer. So we actually were telling women that were at increased risk of an emergency cesarean section that they might want to consider an early epidural in order to avoid the risk of the general anesthetic and that delay. Water births were stopped because of risk of infection. Staff, home births by and large stopped because of staffing issues, if you had fewer midwives, and because the ambulance service in the UK was really overstretched during the peak especially. And partners were stopped from attending in labour, cesarean sections on the postnatal wards and for scans. There was a lot of controversy about that, and that eased up a bit during the lull in the summer, but it started to step up a little bit again now because we're going through a massive peak again in the UK. Meanwhile, back at the RCOG, we started with our COVID guidance, and as JD touched on early on, we had hardly any evidence on which to base our guidance, but the evidence was coming through thick and fast, and we were updating our main guidance there, at them initially perhaps every week or sometimes twice a week we were adding to our guidance. Now that pace of change gradually slowed down, but then we gradually expanded into a whole suite of guidance covering fetal medicine, antenatal care, perinatal mental health, etc., gynecology, etc., etc. So a whole suite of guidance. Perhaps one of the biggest changes was practice with regard to antenatal appointments, and there was a huge changeover in the UK to remote or virtual appointments, videos, using Zoom or Teams or whatever. Slight reduction in the number of ultrasound scans offered to women. You know, still having the most important scans, the key scans, but scans that didn't have quite as strong an indication were fewer. Trying to avoid glucose tolerance tests for women sitting in the hospital for 2 hours, increasing their risk of infection. So I switch over to using HbA1c. A thing that we really should have always been doing, which is making sure that appointments coincide. In other words, if a woman was due to have a scan or a blood test and to see one of us, see a midwife, that we coincided those appointments on the same day. Common sense. We should have been doing that for years, but we were poor at it. Now we're very good. And I switch over to home blood pressure monitoring. As you know, one of the main reasons that the visits become more frequent towards the end of pregnancy is checking blood pressure and testing urine, looking out for preeclampsia. And there's a big switch over to home blood pressure monitoring, giving women their own blood pressure monitor, telling them how to use it, and giving them an app or just a paper list of instructions as to what levels of blood pressure they should look out for. Really good apps that can tell you, you know, if your blood pressure is over a certain level, recheck it in 15 minutes, or that's fine, or go to the hospital. Now, the advantage of that, I mean, in fact, the main reason that this was introduced is to try to keep pregnant women out of hospital as much as possible so as to reduce the risk of infection to them and to staff. And the fantastic benefits to the women in terms of convenience, reduced travel, cost of travel and childcare, and waiting around in busy antenatal clinics for an hour or 2 hours just to see a doctor or a midwife. The disadvantage, of course, is that those are vulnerable or going through safeguarding are more prone to be missed when you're doing everything over Zoom. You know, you can't see perhaps an abusive partner standing on the other side of the screen, threatening the woman. Risk of domestic violence, the sort of non-verbal communication or signs that you would pick up if you're speaking to the woman, you have the woman in your room compared to just over a screen. And we worried that this might just increase the risk of adverse outcomes. We might be missing various things. And in that regard, this is a paper that we published in JAMA back in July. A small study from a single centre, St. George's Hospital in London, looking at the incidence of stillbirth. And it compared about 4 months before the pandemic started to 4 months during the first wave of the pandemic. And the rates of stillbirth are the ones in the rates per 1,000 are the ones in brackets there. And if you get the total number of stillbirths, before the pandemic, it was about 2 per 1,000, but during the pandemic, 9 per 1,000. And we thought, well, maybe this might be due to late terminations, people having difficulty accessing termination. And actually, when you excluded late terminations for fetal abnormality, the risk was still high, 1 per 1,000 before the pandemic compared to 7 per 1,000 during. And this worried us, but we acknowledged that this was a small study with small numbers. And there was some data that were suggesting that this might be a true effect, data from Nepal and also from in India. And we wondered whether this, if it was true, this increase in stillbirths, whether it might be due to reduced attendances, because we showed in St. George's Hospital during the same periods that there was a reduction in attendance to the triage, to maternal fetal assessment units. So the same number of pregnant women, more or less, but they were not turning up for things like a bit of bleeding or reduced fetal movements or feeling a bit feverish, things like that. And we wondered whether this might be feeding a possible increase in adverse outcomes. And this pattern of antenatal care or pregnancy care was mirrored in another RCOG publication, which showed that 70% of obstetric units reported a reduction in antenatal appointments, over half of them a reduction in postnatal appointments, and 60% reducing or removing the offer of home births and midwife-led care units. 86% of units reported a reduction in emergency antenatal attendances. So this was the concern that we had, and 90% of maternity services using virtual consultations. We were concerned about this. Now, at the same time, there was some potentially good news, which is a strong suggestion of a significant reduction in preterm birth rates from a Danish study, one from the Netherlands and one from Ireland. And we began to wonder, well, is all this enforced resting at home reducing the risk of preterm birth? The things that in our mother's generation and our grandmother's generation, the doctors used to tell them to lie in bed and take it easy and don't work. things that we've moved away from in the last 20 years. Was this actually making a difference? I'll come back to that in 1 second. And here we are. We got a lot with regard to stillbirth and preterm birth. I think at the moment this is probably the definitive data. This is from the ONS, the Office for National Statistics in the UK, and they looked at stillbirths and preterm birth in the whole of England and Wales throughout the majority of this year. And what they found is no significant increase in stillbirth and no significant change in the risk of preterm birth, spontaneous preterm birth. So very, very reassuring, good data. So I think the earlier studies that had suggested changes in these outcomes probably can be laid to rest for the moment. What about maternal mortality? I said I'd come back to that. Well, Embrace, the study of maternal deaths in the UK, produced a sort of rapid report on this recently. And they looked at maternal deaths during March, April, and May, so during the peak of the pandemic, the first peak here in the UK. And they found that 10 women had died during this time. And again, dominated by women from BAME backgrounds. And of those 10 deaths, 7 were directly related to COVID and 3 not directly related. In the 7 that were, you see that 6 were cardiorespiratory complications, as you might expect, and 1 a thrombotic death. And in those not directly related to COVID, cases of suicide and domestic violence and homicide. Now, you know, there has been a lot of work, a lot of published work in the non-pregnant population reporting an increase in mental health problems and suicide and domestic violence, as I say, in the non-pregnant population. So it may be that some of these deaths are indirectly related or exacerbated by COVID. And last thing I want to just touch on in my talk today is about the COVID-19 vaccine. So in the UK, right now, there are 2 vaccines that are licensed for use in the general population. The initial one was Pfizer, and just very recently, the AstraZeneca got its license as well. So what is the evidence, what are the data, what are the recommendations about the use of these vaccines in pregnancy? And these data, these recommendations are from the Joint Committee on Vaccinations and Immunizations in the United Kingdom. They initially issued their first recommendations just a few weeks ago and updated them just last week. So what do they say about pregnancy? Well, they say, first of all, there's no evidence of harm from these vaccines, either of these vaccines during pregnancy, but there's hardly any evidence of the use of these vaccines in pregnancy. They don't expect that these vaccines will cause problems in pregnancy based on going back to first principles, but the evidence just isn't there. So the conclusion is that you cannot recommend these vaccines for routine use in pregnant women, as they're recommended for routine use in the rest of the population. But, and this is what's new last week, if the risk of exposure is high, in other words, healthcare professionals, for example, or perhaps teachers, or if there's a high risk of serious complications, if the woman does get the infection because she has underlying conditions, you should consider offering the vaccine. And clinicians should just discuss the risk and benefits, as well as being open and transparent about the lack of data around the safety of these vaccines in pregnancy. What are the risks and benefits? Well, the benefits are a high chance, especially with the Pfizer vaccine, a high chance of protection against getting COVID. What are the risks? We don't know. But what are the risks of if you do happen to get COVID and you have underlying conditions? The risks are significant, as we've seen. The other thing that the JCVI updated last week is that they feel there's no need to do a pregnancy test before vaccinating, and if somebody's vaccinated, they don't need to delay pregnancy after vaccination. They had previously recommended delaying for a couple of months after vaccination. Again, there's not much data to back up this recommendation. And with regard to breastfeeding, again, no known risks, again, not much data, but it seems extraordinarily unlikely that this vaccine is going to cause a problem for a breastfeeding baby. And there are well-recognized benefits of breastfeeding, as you all know. And so the recommendation, therefore, is to recommend this vaccine to breastfeeding women. So I hope our focus is going to turn to restoration and recovery soon. We had published this in June, hoping that any second wave wouldn't be that bad, but it actually is, and it seems to be possibly worse than it was first time round. We hope that it'll all pass in the next sort of couple of months, and then we can sort of turn our attention to restoration and recovery in both obstetrics and gynecology. Thank you very much for your attention.
Thank you, sir.
Thank you, Professor Pat, for an excellent, brilliant talk on COVID. I have some questions. One is about the preterm delivery. Even though the UCO study shows that it's 27%, and in the living systematic review, it is 17%. What we observed in Kerala is it's less than 10%. So we are doing a multi-center study involving all the main COVID centers in Kerala. And till October, we have data. The preterm delivery rate is actually less than 10%. What is your opinion on that?
I think it's very interesting. You know, I think it started off when this came first. There was a feeling that if a woman had COVID, that it might be beneficial to her health to deliver the baby, even if it was premature, because we'd seen in the swine flu pandemic that women tended to get a lot better once they were delivered. And I think as the early months passed and we got more experience, we began to realize that you didn't necessarily have to deliver these women early. And many of these women, if the COVID wasn't too bad, didn't seem to benefit hugely from having the baby delivered. So that was the first thing. I think as we gain more experience, fewer of these women are automatically being delivered by cesarean section as a knee-jerk reaction to having COVID. And then I think the data on spontaneous preterm birth are emerging. I think if you've got data from there, you should definitely publish them, because I think this is still an unanswered question, because it's very hard to explain why there was apparently such a dramatic reduction in spontaneous preterm birth in those early studies from Ireland, Denmark, and the Netherlands, whereas it seems to be less prevalent now in the bigger studies. It may just because these were small studies, but really if you've got some data there, do publish them, and then we can pull them all together in a meta-analysis to try to get the true answer.
So another interesting thing what we noted is that we have data about 3,500 COVID positive pregnancies, and out of this actually only 0.7% had a severe infection that is needed ICU admission. But unfortunate thing what we noted is that about 20% of the severely infected patients died. That is about 7 maternal deaths out of this. It's a very rare thing, but when it is a severe infection, there is a high chance of maternal death. That is one situation we noted.
It's a very good point. I mean, one of the reassuring things about the most recent UCOS paper, the one that hasn't been published yet, is that of all the women, the pregnant women admitted to intensive care, 92% of them ended up being discharged from hospital by the time we're publishing this paper. So that was quite reassuring. Those are better data than the general population being admitted to ITU, certainly at the moment. So I think, you know, numbers are small, so it's hard to draw firm conclusions, but it's reassuring in the sense that it does not look like the outcome for pregnant women admitted to intensive care is any worse than the rest of the population in the UK.
So another point about the newborn infection, even though you mentioned it is a rare thing, what we noted is about 14% of the babies are infected. Even though all the babies are fine, there was only one neonatal death, but 14% of the babies are affected. 1.4%.
That's interesting, isn't it? I mean, we published this meta-analysis back in July, where we pulled together all the data at that stage. And I think there were about 2,600 at that stage. And the proportion of babies infected, or testing positive, I should say, in the first week after birth was only about 2.5%. And of those, at least in those published studies, none had serious infection. And many of them, in fact, were tested only because the doctors knew that the mother had the infection, so wanted to test the baby. So, you know, I think still numbers are small, but again, they'll be updating this meta-analysis. The living meta-analysis, I think, will be, or the living systematic review will be really useful to, as more and more data are published, to put it all together and get true, you know, answers when it comes to these rarer outcomes.
Thank you, Professor Pat.
Thank you so much, Dr. Patrick. I think that lecture was a fitting finale to the extremely wonderful session that you had from 3:30 onwards. And with all the knowledge that we have gained till date from managing COVID in pregnancy, I hope we tackle the mutant variety or the second wave in a much better manner. And we hope and pray that the morbidity and mortality can significantly be reduced. Thank you so much, sir. That was a wonderful lecture.
Thank you very much.
Sherien, sir.
Thank you.
Sherien, sir.
Thank you very much, Pat, for that wonderful presentation. And
Sir, Radhamani Madam has some questions to ask.
Okay. Dr. Radhamani, please.
Sir, we had two unusual case presentations. One patient actually at 34 weeks, she was admitted with the pain abdomen, but ruled out abruption, urinary tract infection, preterm labor. As she is positive, COVID positive, we shifted the patient to the COVID ward. 2 days later, sudden intra-uterine death occurred. The patient was appreciative fetal movement. Ctg was also reactive. And thinking it is abruption, we did a DIC panel, but the fibrinogen was less than 60, and then platelet also reduced with the PTINR 1.4. So maybe I thought it is a diagnosis concealed abruption, but after cryo, FFP and platelet, we operated the patient, but there is no abruption, but umbilical cord thrombosis is umbilical cord, and then and also small hemorrhages throughout the placenta. This was one finding wherein within 4 to 6 hours, this was the finding with the DIC panel. Number 2, another case actually, after admission, the LFT was deranging. Day by day, the LFT was increasing. So once it becomes 600, then we terminate the pregnancy by cesarean section, and the postpartum LFT improved. Anyone have this type of experience?
There is some preeclampsia risk like syndrome that is described in COVID now.
That was normal.
Okay, Pat, unmute and give your comments. Yeah,
I mean, very interesting. I mean, I think the bottom line, we're still learning about all this, and you know, the more information we get about COVID, the more it seems to exert its influence through a thrombotic mechanism. Although if you look at the maternal deaths here, the majority were cardiorespiratory as opposed to thrombotic. But still, thrombosis is clearly a major thing. It's very interesting about the umbilical cord thrombosis there. That's very interesting. I guess for COVID to do that, number one, the baby would have to have the infection, and we think that's possible, although in a very small minority. And then to get a thrombotic episode in the cord would be very rare, I guess, as well. So who knows if they're related? I mean, all of these case reports I find very interesting because this is still an emerging disease when it comes to us learning about the pathophysiology. So really interesting to hear those data. Thank you very much.
Thank you, Pat. Thank you all the speakers and all the chairpersons for conducting the session very well, and we enjoyed the presentations from all the international faculty, and all the attendees who are attending the conference might have benefited. Thank you all, and once again we are grateful to all of you, the panel discussion, I mean the chairpersons as well as the speakers. See you sometime soon in person. That is our wish, to see you in person sometime. So thank you once again. Thank you, Jaideep.
Thank you, sir. Good night. Lovely presentation, Pat. Thank you.
Thank you. Right. Thank you. Once again.
Good night, everyone. Stay safe. Bye-bye.
Good night.
Good night.
Bye-bye.
Right. Thank you, Betsy. Right.
Thank you all. We officially ending our program.
Thank you, sir. Sir.
Thank you. Thank you very much for joining.
ഇത്ര അന്ന് തൃശ്ശൂർക്കാര് ചെയ്തപ്പോ നമുക്ക്
You are
വേണ്ടതെന്ന് തോന്നിയതാണ്.
You are online. Okay, good.